Can we start the YouTube, which I think we have?
We're up.
Great. And I think we, 1, 2, 3, we're almost at a quorum.
I think we now have it.
Okay. Welcome to the Education, Health, and Environmental Affairs Committee for our hearing of the day. I apologize for the lateness. We did go longer on the floor of the full Senate, in which we met this morning. We have, I think, a number of bills today, 8 to 10, 11 bills. We will be starting with Senator Griffith. We'll come back to Senator Land 379. I believe he's in a meeting or in another committee. To the public, you may not see all committee members all the time. Some will be testifying on their bills in other committees. The lead proponent behind the sponsor may speak for up to 5 minutes, and subsequent speakers can go up to 2.5 minutes. You are not required to use your full time, and I will try to let you know if there is no opposition, oral or written, to the bill, and I would suggest you consider adjusting your testimony accordingly. That being said, we will go to Senate Bill 565, and that is Senator Griffith. Welcome. And she will be followed by Dale Jafari, Nyla Russell, Kathy Ware, and then Donald Balassa. And I do not see, hold on one moment. I see no one in opposition to the oh, I'm sorry, I had the wrong bill.
I was getting nervous. I was like, oh,
Should
those aren't my panel.
Yeah, that's, well, now I'm really confused. Hold on one moment. Yeah. No, Senator Eckert's bill would have been a great success, but it wasn't. Just be patience with me for a moment as we order back in shape. I apologize. Senate Bill 565, Public Health Data, Race and Ethnicity Information. Senator Griffith will be followed by Craig Beam, Pam Casemeyer, and then Aaron Dorian. And it's unclear if there's any opposition. Yes, there's some, but it is written only. And people can look at the testimony if they want further clarification on the favorable or opposition, which is all included in the file. With that, Senator Griffith, please, welcome.
Thank you. Good afternoon, Mr. Chair, Madam Vice Chair, and colleagues. I'm pleased to be with you again. Happy to be presenting today Senate Bill 565. This bill is one of the bills that is recommended for your consideration by the President's Work Group on Equity and Inclusion. I heard the chair's instructions, so I'll be very brief. I know that you all received a packet of testimony favoring this bill. Also, this bill is introduced as a cross-file to a House bill, which is sponsored by Delegate Jocelyn Pena-Melnick. It is a bill that simply helps the state make data-informed decisions around health. It requires the Director of the Office of Minority Health and Health Disparities to work with the Maryland Health Commission and the Maryland Department of Health around the use of and publishing of data to include race and ethnicity information so that we can identify areas of improvement. I know you all have been hearing all session the challenges related to health disparities. We've been hearing all year examples of how health data can inform our interventions. So, Mr. Chairman, if I could, I'll go ahead and turn it over to the panel to talk about Senate Bill 565 and request a favorable report. I'm available for any questions should they arise.
If you can wait a few minutes, we'll hold the questions until all the proponents speak.
Sure.
So thank you for the brevity and the explanation. Let's go to Craig Beam or Bem from CRISP.
Yes. Good afternoon, Mr. Chairman. Thank you so much for having me. My name is Craig Bem. I am the Maryland Executive Director for CRISP. We're the state designated health information exchange. I just want to note that we are not the right people to speak to policy, but I can certainly speak to the data and the IT requirements and burdens that are included here and have no concerns whatsoever. We support this bill. Certainly anything that can be done to gather data securely and effectively and make it transparent to drive database decisions is the right thing to do. And our experience with the Department of Health, Healthcare Commission, Office of Minority Health is that they certainly will use that data to do good things, and we want to help serve it up. And maybe I'll use one brief example. Certainly COVID-19 has been, unfortunately, an area that's highlighted a need for data to address and understand potential healthcare disparity. CRISP worked very closely with all the offices involved that we've talked about to pull data, to provide reports, to keep them maintained. And we think this is something that can be very much done in other ways to drive better decision making. We're doing the same thing now with the vaccine administration in different sites to make sure that all the most vulnerable populations have the same access to the same medications and treatments as everybody else. So again, I'll also be very brief and just say more data is good so long as we can do it securely and appropriately. And my opinion is that this bill certainly does all of that while maintaining a very low burden. Thank you.
Thank you. Thank you, Mr. Beam. Let's go to Ms. Casemeyer.
Hello, Mr. Chairman and members of the committee. Pam Casemeyer here on behalf of both the Mid-Atlantic Association of Community Health Centers and MedChi in support of this legislation. As you all hear quite often on different subject matters, data collection and analysis is an important part of any policy development. And this bill would increase the access to data on race and ethnicity, as we're working very comprehensively to address health disparities and other inequities. And so this bill requires the boards to try to collect this information from the licensees so that we can start to look at the diversity or the race and ethnicity of our healthcare provider, as well as in the community as we begin to shape policies. The Healthcare Commission already is required to do a healthcare disparities report card report, and this would then incorporate information on race and ethnicity related to our provider community as well. We think it's a good advancement in terms of the range of data we'll have to look at this issue as we continue to work on it going forward, and would recommend a favorable report.
Thank you, Ms. Casemeyer. Ms. Dorian.
Thank you, Mr. Chair, members of the committee. My name is Erin Dorian, and I'm the Director of Government Affairs and Policy for the Maryland Hospital Association. Over the summer, the MHA Executive Committee adopted MHA's commitment to racial equity. While much of this work is internal to the hospital field, we understand there's a need to adopt public policies to promote racial equity in the healthcare sector and beyond. I'd like to thank Senator Griffith for introducing SB 565, which, as you've heard, seeks to improve data collection of health data stratified by race and ethnicity, as well as the data needed to build a diverse workforce. Any of these efforts will require access to robust, accurate, and Maryland-specific data. We have many of the tools in the toolbox to do this. We just need to coordinate them better. Furthermore, to truly build a healthcare workforce that reflects Maryland's population, we'll need to know the demographic makeup of the current healthcare workforce. There are other states that do this very well, much better than Maryland, and we believe that Maryland could be a leader here. We believe SB 565 helps to build the critical data infrastructure needed to inform future policy efforts in reducing health disparities and increasing health equity. For this reason, I urge a favorable report on SB 565.
Thank you, Ms. Dorian. Are there questions for the proponents, including the sponsor of the bill? Senator Carrozza.
Thank you, Mr. Chair, and I thank the Senate sponsor and the organizations that testified in support. And my only question is, I think we're all in agreement about the need for the data, I was just looking at the letter from the Board of Professional Counselors and Therapists, and they were saying that their applicants are not required to complete the ethnicity section of the application for licensure and certification. And as a result, the board cannot accurately publish or provide a racial and ethnic composition of all individuals who hold a license certificate issued by the board. So I just read that. So I just wanted to give the sponsor or anybody else an opportunity just to respond to that.
Thank you. I appreciate the question, Senator. Having reviewed that letter, my response is simply this: a little data is better than no data. And one of the things that the bill was careful about doing, that we were careful about doing, is not requiring people to report race and ethnicity data. And so just like any other area, even with minority business or any other area where we're collecting data, there is a category that says not, no response or not answered. We want to begin to identify those that are willing to share so that we can identify where there may be gaps in our workforce. If people choose not to respond to those questions, we can at least make some decisions based on the data that we are able to collect. And it's one of the reasons that we were very careful to do that, is out of respect for people who might choose not to report. And it's also one of the reasons the bill can be accommodated without increasing the fiscal impact to the state.
So you're okay if it's incomplete information, you still would find that information helpful?
Absolutely. You start with what you have and build from there.
Further questions, committee? Further questions? Seeing none, that concludes the hearing on Senate Bill 565. Thank you, Senator Griffith, for appearing. Thank you, and all the witnesses. Senator Lamb, would you mind if we go to Senator Eckert? She has one bill, you've got three. If she's been waiting, she came in while you were out.
Yeah, that's fine.
Okay, then we will go to Senate Bill 476, Health Occupations, Nurse Delegation of Tasks. The sponsor from the Mid-Shore, Senator Eckert, will be followed by Dale Jafari. Now it's the right list I'm reading.
That's right.
Naylor Russell, Kathy Ware, followed by Donald Balassa. And what I said earlier still holds. There is no opposition to the bill. Senator Eckert, welcome as always.
Thank you very much, Mr. Chairman and Madam Vice Chair, co-chair, excuse me, Vice Chair, whatever, it's after lunch. And Senator Lamb, thank you so much for yielding. I appreciate that. And this will be brief, I'm sure, because actually this bill passed in the House last year and didn't get an opportunity to get over here in time because of the conflict between sine die and crossover. So this bill essentially clarifies something in the Nurse Practice Act that needed to be clarified. Current law says that both RNs and LPNs may delegate tasks. And so then those unlicensed caregivers or persons whom they delegate the task work under their license, either an RN or an LPN. And it doesn't clearly state in the Nurse Practice Act that the APRNs are able to do that. So this merely clarifies who can delegate, as long as it doesn't become a routine part of the unlicensed individual's job duty. Senate Bill 476 allows the APRNs, the advanced practice nurses, to delegate nursing or technical tasks as a part of their regular job duties, as long as the assistant is trained in performing the task and the APRN provides the instruction and the supervision of that individual. To remain on site and available should need arise. And the bill requires the Board of Nursing to adopt regulations regarding the delegation of those tasks. Because of the pandemic, it's become acutely clear to me and to others that we had a healthcare shortage to begin with, but we will need all hands on deck as we move through the vaccination process to be able to get back to, quote, whatever normal is following the pandemic. And there's been a growing need for healthcare professionals in the field, as you can imagine. So I would urge your favorable consideration and ultimate passage of this bill to get these definitions clarified as to who can delegate what under the Board of Nursing. Thank you very much.
Thank you, Senator Eckert. Ms. Jafari?
Good afternoon, and thank you for the opportunity to speak to you this afternoon in favor of Senate Bill 476. My name is Dale Jafari, and I'm a doctorally prepared nurse practitioner who lives and works in Talbot County, Maryland. My service area includes Kent, Queen Anne, Caroline, Talbot, and Dorchester counties. I speak on behalf of the Nurse Practitioner Association of Maryland, the only professional organization advocating solely for over 7,100 nurse practitioners in Maryland and the more than 800 members of NPAM. I work with an office staff of physicians, certified nurse midwives, nurse practitioners, registered nurses, certified nursing assistants, medical assistants, and administrative staff. We travel to remote sites to improve access to care and to remove the barrier of transportation in our very rural and often medically underserved populations. We don't have a choice in which of the assistants or administrative personnel come with us to those remote locations. And particularly in the midst of the COVID-19 pandemic, where we need to be able to utilize all skill sets at all levels, we cannot be selective regarding which assistant is going to leave the Easton location to move to one of the other locations. Like the independent nurse practitioner practices, this creates a conflict with the lack of clarity in the current language regarding delegation to non-licensed, properly trained and educated medical assistants. A chaperone is required with every exam in women's health. I need someone who can measure vitals, who can chaperone me during the exam, who can assist me with procedures, administer immunizations under my direct supervision, and room the patient while decontaminating that room and setting for the next patient. Without my right-hand woman, I would see fewer than half of the patients I currently see daily for evaluation and treatment of common acute conditions, well woman exams, and management of chronic long-term conditions, education and counseling. There would be a loss of patient access, and a more costly resource, such as a registered nurse or a nurse practitioner, would be required to perform the tasks that are well suited to a less expensive office member. I respectfully request a favorable review of Senate Bill 476, particularly in light of the recent support from the Maryland Board of Nursing. They have submitted a letter in full support of our request, recognizing that the clarification in language is necessary. The delegation of nursing tasks passing would help to ensure that my patients and your constituents continue to receive the highest quality of evidence-based care available. Thank you.
Thank you, Ms. Jafari. Let's go to Nyla Russell from NPAM.
Yes, good afternoon, and thank you for this opportunity. My name is Dr. Nyla Russell, and I'm a family nurse practitioner practicing in Charles and St. Mary's counties and a resident of Charles County. I'm testifying today to ask your support of Senate Bill 476. I'm a dermatology nurse practitioner, and I safely and efficiently see 4 to 5 patients an hour, doing a massive number of procedures, and the only way that I can do that is with my competent and skilled medical assistant. She drives the pace and keeps me on track throughout the entire day. I'm employed by a physician-owned dermatology practice that's affiliated with a large medical group, and I don't get to say who works with me or for me. Because our group will choose the best person for the job, as they rightly should, that person may be a medical assistant. And legally, I only supposed to delegate to my medical assistant when the physician is in the office. We practice out of a number of locations, so 2/3 of my time is spent without a physician in the building. As a registered nurse, I have the ability to delegate to a medical assistant, and I'm simply asking that this language is updated to reflect our role as independent providers in the Maryland healthcare system. We provide high quality access to care that is cost effective and safe, and I can't do this without the aid of my medical assistant. Because of this, I'm asking that you will allow nurse practitioners and medical assistants to serve our communities with clear, updated language. As you've heard, this bill easily passed the 2020 legislative session in the House, and I'm requesting a positive report from the committee today. Thank you so much.
Thank you, Dr. Russell. Let's go to Ms. Kathy Ware.
Yes, thank you. Good afternoon. Mr. Chairman and members of the committee. My name is Kathy Ware and I live in Queen Anne's County. I recently retired from my specialty practice on the Eastern Shore, and I am also a member of the Maryland Medical Reserve Corps. I will be working with the COVID-19 vaccination program in Anne Arundel County and in any other jurisdiction as needed. As you've heard from Senator Eckert and from my colleagues, Senate Bill 476 seeks to clarify ambiguous language in the Nurse Practice Act to specifically include advanced practice registered nurses. In my work with the COVID-19 vaccination program, I will need to delegate tasks to properly trained assistants so that I can be more efficient in safely vaccinating, educating, and monitoring some of Maryland's most vulnerable populations. In fact, it has come to my attention that because many COVID vaccination sites do not have a physician on staff, medical assistants who would typically be able to vaccinate are not able to volunteer. As the COVID vaccine program continues to expand, we are going to need as many vaccinators as possible to meet the need, especially in rural and underserved areas of our state. During this pandemic, it is vital for me and for every healthcare provider to practice to the highest level of our education and training. One more point I'd like to make is that currently my nurse practitioner colleagues who own private practices have less flexibility in hiring staff, and their staffing costs can be prohibitive. This can be detrimental to the viability of the practice, and since many of my nurse practitioner colleague practices are in rural areas, closures could affect access to care. This bill will allow nurse practitioner practices to be more cost-effective and sustainable. I respectfully request a favorable report. I thank you for your time, and I'd be happy to answer any questions.
Thank you, Ms. Ware. Let's go to Donald Balasa.
Thank you, Mr. Chairman. Senators, this is Don Balasa. I'm the legal counsel for the American Association of Medical Assistants in Chicago, also representing the Maryland Society of Medical Assistants. I have nothing to add to what has been stated, and we are in full support of this bill. Thank you.
Mr. Balasa, are you in Chicago and are you shoveling snow?
Yes, indeed. Yes, indeed. I could show you the 10 inches outside my window, but rest assured that it's very cold and very snowy.
Okay, well, thank you for the weather update. Questions for the sponsor or the advocates? Senator Washington.
Thank you, Chairman. Thank you. Again, I'm the adult child of a nurse, so I very much respect the nursing profession. And these questions are really, they're not to be hostile, but really real questions. So when you're delegating to other, you're saying that the board will adopt regulations regarding this. So physicians, doctors are able to delegate to a physician's assistant, right? So is this kind of the parallel? No. Okay, so help me understand what tasks would a nurse, so an advanced degree nurse, delegate? I saw someone, maybe it was Ms. Ware, maybe?
Yes, hi, I can answer this. I wasn't sure of the protocol. I wasn't sure if Senator Eckert was supposed to answer.
Was Senator Eckert or?
Yeah. I'm not sure.
I want to understand if there's a parallel construction.
Yes. I was shaking my head because a physician assistant is a practitioner that is sort of that's not who we're talking about. We're talking about a medical assistant. So the tasks that advanced practice registered nurses can delegate would be things like measuring vital signs, assisting with procedures in the office. In my own practice, which I retired from, it would be making some leg measurements. My colleague who works in women's health could give more examples. I could delegate giving a vaccination. So I was shaking my head primarily because physician assistant is actually more of a provider that would be along the lines of an advanced practice registered nurse. It's the language
right.
of medical.
Yeah, so sorry, I was trying to draw sort of a parallel construction.
Yeah.
So right now, as a nurse, you are not able to delegate anything to any other
No, as I am allowed as a registered nurse, but
Yes.
as a nurse practitioner, which every advanced practice registered nurse is,
Yes.
because of this ambiguous language, I'm not allowed to. So there's a lot of, ambiguity in the language, and this would simply clear the ambiguity.
And so I guess I am asking, and this is just to follow up with that, to clarify further, the training of the person to whom you're delegating certain activities. So that's really what I wanted to get to. There's a difference between a GNA and an LPN and a medical assistant who went to an online program, and, no disrespect for these, but, for 3 weeks and has a certificate. So I just want to understand what's the training of the person to whom we'd be relegating.
Yeah, it's very reliable, very good question. And my colleague, Dr. Jafari, will answer that.
So there are, as you said, multiple different levels of education and multiple different certifications in various and sundry things, such as a certified nursing assistant, a certified medical assistant, a medical assistant lacking the word certification, and multiple different educational programs for those assistants prior to their introduction to healthcare practice. The big question is that we may not know in a larger business setting who is what. Their role is the same. They're all performing similar tasks in an office setting under the direct supervision of the nursing staff or the APRNs, or in my case, the cadre of advanced practice and physician providers that are present. When we go to other locations, once again, we may not know the background, the educational background of the person who comes with us, only that their role is as a medical assistant in our organization and that they are there to provide the services as described by Kathy, the things they would do in my practice. Again, chaperoned for a visit. So obviously I am in the room with them at that time. When they're rooming the patient, they are obtaining basic information, which I review when I go in to see the patient. They would administer an immunization that I have seen, evaluated, and ordered once I know that they have been appropriately trained in the administration of such an immunization. So those are the types of tasks that are being delegated to them. The educational background, I don't know how to resolve the issue that we have with such a huge, wide, and varied type of program that's available. The physicians currently can delegate to anyone. And back in the olden days, and I guess I date myself at this point because 40 years ago when I started, we didn't have a whole lot of certified programs. So basically what you had was somebody who had a strong interest in assisting in an office, and they were given on-the-job training, and they were the office assistant. So we've seen a tremendous evolution for the health and safety of our patients in terms of being able to properly educate and certify these people. And now that they are being hired in various practices, we need to be able to delegate to them just as we would a certified nursing assistant.
Thank you so much. Mr. Chairman, I get that, and I support that moving forward. It's this part, lines on page 2, lines 21 to 26, where it talks about that the assistant performs only tasks that the assistant is trained to perform. And so if there's some way, so for example, your CMA, you're certified in a setting, you'll have the GNA who's providing care, care support. You have a CMA who's a certified medical assistant who has more training, and then you go on. So, I would think that there should be some way to ascertain, and if there is some way to specify it at certain levels of education, I think that might help resolve some concerns I might have about certainly concerns I have in other practices, but since this is the bill before me, before us, I'd like us to figure that out. So Chairman, I'd like to follow up and if we could talk about how we could make sure that the person is truly trained to perform the tasks that are being asked of them.
Can I respond to that?
Yeah.
Yeah, before you do, Senator Eckert, just to be clear and following up on Senator Washington, these are unlicensed generic medical assistants, and they are trained in certain duties by the delegating authority. Is that correct? I see a shake of the head of Ms. Jafari. Okay. Senator Eckert, back to you.
Thank you very much. I was just going to respond that if you look at the bill, it says that the Board of Nursing will provide the specifics on this, I believe. It's in there, and that they're the kinds of activities that are identified in the Nurse Practice Act. So I think that will, as with the rest of the scope of practice with the various levels in nursing as described therein, that would be a part of what would be promulgated by them.
If I might also add that there's also a component of verifying competency in our practices. So it's not only we're training for these tasks, we're delegating these tasks, but we're also verifying competency. So we're as a quality measure.
And are these only in your office setting, or does this apply? I'm trying to see, because it seems like it will apply to any setting. And so then it's
if I might respond to that, as I'm an advanced practice nurse, regardless of the setting, I would, if I were delegating things that were described in the scope of practice of the person who was working under my license, I would be the legal accountable authority. So I would never authorize somebody to do something that I was not comfortable assuming that responsibility. So I want to make sure that individual is truly competent in the tasks that I had delegated to them. And the double, I guess, protection is it's also protected through the scope of practice as spelled out in the Nurse Practice Act.
Thank you, Senator. This is
hold it.
Saying thank you.
We're good. Senator Washington, that doesn't preclude, even though the nursing board can promulgate regulations, it doesn't preclude you or anyone else of being more detailed and refined in the definitions.
Yeah, and this is just out of my utmost respect for the nursing profession and what I've seen happen to it and you. And so thank you so much.
Okay, Senator Ellis.
Thank you, Chairman Pinsky, and thank you, I was going to say, doctors and Senator Eckert for this bill. I too come from a family of many nurses. My late mom was an RN, and you know, my brother is currently an RN, and so many other family members, and so I really understand some of the issues. I think Dr. Ware was referring to when she's working in a large practice and going in a new area with new people, the authority to delegate. And I think I did not follow you correctly. Are you saying you don't know, you really have no way of knowing the qualifications of those folks in, say, another office that you have to go to, and it's like potluck? And will this bill help that?
This is Dr. Jafari, and that was my statement.
Okay,
and no, not at all. These are the staff that we work with every day. We are in a main location, and then we have other sites off that main location, and people from the main office accompany us to those sites. So every single individual who is there has been through the same vetting process.
Excuse me, ambulance is going by my office here, and so could you say that again? I just didn't hear.
Sure.
Interference.
We have a main office in which all staff start, and then we have other sites that we travel to, and it is those members from the main office who travel with us to those sites. Every single person in that office setting has been vetted prior to hire for the role that they have assumed in that office, and all have the same competencies and requirements. I was referring to specific information about which individual might be a certified nursing assistant versus a GNA versus an MA.
Yeah, so when you go to a remote site, the point you were making is that you don't utilize those folks because you don't know their qualifications?
So under the way the language is currently written without the clarification, then we send only those who are certified nursing assistants to work with the certified registered nursing practitioners. And again, it goes back to the skill set comment that I believe Dr. Russell made, where some are better skilled at some things than others are, but we don't have the luxury of selecting by skill set when we have to select by title.
And so thank you for that. So how will the changes in this bill affect you being able to work with folks at remote locations when you go to those locations and you don't know those people?
So with that clarification in the language, then they could select a person with the best skill set for the particular things that are going to be done at that office on that day. Different procedures are done at different times and at different locations, and all of that can be matched. In the main office, it's not a problem because we can interchange people on site. We don't have that luxury in the outside locations.
Okay, well, thank you for that explanation, Doc. Appreciate it.
Thank you. Seeing no further questions, that concludes the hearing on Senator Eckert's bill 476. Thank you, witnesses. Thank you.
Thank you.
Thank you very much.
Thank
We're going to go back to Senator Lamb. We'll start with 379 if he doesn't object. This is registration of audiology assistants. We'll be led by the sponsor, Dr. Senator Lamb, followed by Dr. Alicia Sporer, Dr. Brianna Holton, and then Candace Robinson.
Great, thanks, Mr. Chairman. First, bring up the slides for this presentation. So this is Senate Bill 379. Good afternoon to the committee, the chairman, and other members. For the record, Clarence Lamb, Senator in District 12. So this bill seeks to improve patient safety by licensing audiology assistants. This is really to create a licensure for audiology assistants. And Lamoria, if you're there, if you can bring up the slides. In addition to standardizing the requirements for audiology assistants, this bill will help ensure that audiologists have—
One second.
Go ahead.
No, I was saying give me 1 second, but you can go ahead.
Yeah, okay. All right, I'll keep going. Thank you. This bill will help ensure that audiologists have more time to provide patient care. During the pandemic, we have seen now more than ever in many ways that providers are stretched thin, physicians are stretched thin, and other healthcare workers as well. This does impact patients' accessibility to care, and in the case of an audiologist, it specifically impacts the disabled, elderly, and pediatric population's accessibility to care. Audiology treatment is one of the few areas of care that cannot be conducted efficiently via Zoom for the obvious reasons. During the ongoing pandemic, practices have had to cut down on the number of patients that they treat due to the time-consuming but necessary disinfection protocols required for providers that are seeing patients physically in their office. This bill aims to lessen that burden on the community, as well as ensuring that our constituents have the best quality care moving forward. The bill, as originally drafted, called for the registration of audiology assistants, but at the recommendation of the board, we have requested an amendment to change the registration to a license. If you can skip to the next slide. In addition to, if you go ahead one more slide. So in here, you can see that this is a more in-depth explanation of the duties of the audiology assistants. In addition to the disinfection protocols that I mentioned, audiology assistants are also responsible for many other important tasks that help the patient and the audiologists and providers in the office. You can go to the next slide. The biggest reason to move towards licensure of these audiology assistants is that it helps create standardized requirements for them and also standardize the supervision for these assistants. Currently, most audiology practices in Maryland use unregulated assistants to support the work of audiologists. The state doesn't have any current supervision requirements or standards of care to be met. In addition, the state has no pathway to sanction audiology assistants for any inappropriate behavior. We believe that the state does have a public health interest first in adopting oversight of these audiology assistants to ensure our residents are safe and receive proper medical treatment at these practices. The bill will include basic requirements for audiology assistant licensure, such as having a high school diploma or equivalent and a clean background check. Another important reason to implement this bill is the economic benefits that can be associated with it. Various analyses have determined that licensed audiology assistants earn on average $17 per hour. And with our laws, 2 assistants per audiologist clause, we may introduce up to 900 jobs in the state with this provision. The comfortable wage will be accessible to just about anyone who chooses to practice a career in audiology and supportive ancillary services, and also can pass a background check. So in times of COVID-19 and the accompanying unemployment levels that we're seeing, this is also a nice benefit of this legislation. Next slide, please. This map shows the other 22 states that currently license or register audiology assistants. And as you can see, our neighbors in West Virginia, Pennsylvania, and Delaware have all passed similar legislation along the lines of this bill. Next slide. As has been stated, the bill also sets requirements to become an audiology assistant, requires that assistants be supervised by a licensed audiologist, and allows the board to take action against any unethical behavior. Next slide. So in closing, licensing audiology assistants will help really improve patient safety, help expand access to jobs that pay above the minimum wage with low barriers to entry. Will also help improve audiology care by allowing audiologists to spend more time with their patients and also expand their practices. We believe this bill will not only help those that are disabled, elderly, and pediatric populations in particular who so often find themselves in audiology offices, but are also working on behalf of advancing the health of residents in the state as well. So with that, let me close and turn it over to members of the panel. Thank you.
Thank you, Senator Lamb. Let's go to Dr. Spohr, followed by Dr. Holton.
Thank you, Chairman Pinsky, Vice Chair Kayan, and members of the committee. My name is Alicia Spohr, as mentioned, and I'm an audiologist and small business owner in Howard County, and the current legislative chair for the Maryland Academy of Audiology, here in support of Senate Bill 379, licensure of audiology assistants. The MAA is pleased to be working with Senator Lamb and Delegate Ariana Kelly to introduce audiology assistants to the hearing and balance healthcare system. As a brief reminder from what Senator Lamb just reviewed, audiologists are licensed professionals who specialize in the diagnosis and treatment of hearing and balance disorders and have an 8-year clinical doctorate degree. We work with patients of all ages from birth to earth and in a variety of settings, including but not limited to private practices, hospitals, school systems, and the Veterans Administration, providing the entry point for individuals with hearing, tinnitus, which is ringing in the ears, and balance concerns. Generally speaking, audiologists are to the ears what optometrists are to the eyes. Currently, patients who need hearing and/or balance services see a doctor of audiology. There are more than 450 licensed audiologists in the state of Maryland, but the demand for services can become a burden for individuals with acute onset problems as the population increases and individuals live longer. And with breakthroughs happening in medicine every day, the connection to the ear plays an important role in diagnosis or management of other disorders. Additionally, the COVID-19 pandemic has highlighted the access difficulties. Longer wait times at practices are now required due to the time needed to clean and disinfect common spaces, and could be more than 3 weeks in rural locations like the Eastern Shore, where there are a limited number of providers, or in practices that were already busy before the pandemic hit. The 450 licensed audiologists in Maryland are working diligently to provide the highest level of care, but we cannot do it alone. SB 379 would license audiology assistants in Maryland and give the audiologist an extender in the hearing and balance healthcare system. Audiology assistants will provide another set of hands or two in a practice and can reduce the backlog by seeing patients for routine and troubleshooting problems. My colleague will review some of the common duties that will be assigned to audiology assistants, but this legislation will provide additional access for patients who need services provided by or supervised by a licensed audiologist. Audiology assistants will also allow the audiologist to work to their highest scope of practice, completing diagnostic testing, working with pediatric patients or those with special needs, working with individuals who have surgically implanted auditory devices like cochlear implants, and treating tinnitus and balance disorders. Maryland has set a precedent of licensing individuals who directly and indirectly work with patients, and this bill mimics that of medical, dental, and chiropractic assistants, ensuring consistency at the state level and ultimately patient safety. As you heard, there are 22 other states that have passed law for audiology assistants, with more introducing legislation this year. Since audiology assistants will be supervised by a licensed audiologist, the educational requirements are a high school diploma or equivalent. This can help drive young individuals into the healthcare system if they are interested in pursuing a medical path, but are not yet sure of their area of interest. The position may also be ideal for individuals who are not interested in college education, those who are retired but would still like to work in a helping profession, and those who cannot commit to a full-time work schedule due to children or caregiver requirements. To ensure patient safety and support from the Board of Examiners, the legislation also requires audiology assistants to be of good moral character, demonstrate oral competence, and submit to a criminal background check. The MAA concurs with both of the Board of Examiners amendments presented. We have been pleased with the unanimous support of the legislation in the HGO committee yesterday. Thank you for your time today and to Senator Lamb for sponsoring the legislation. We ask for your favorable committee report on Senate Bill 379.
Thank you, Dr. Spohr. Dr. Holton.
Chairman Pinsky, Vice Chair Kagan, and members of the committee. My name's Dr. Brianna Holton, and I'm here on behalf of the Maryland Academy of Audiology in support of Senate Bill 379, the licensure of audiology assistants. I have been practicing audiology in Maryland for over 23 years and currently co-own an audiology private practice with 11 office locations in Maryland, including the Eastern Shore. The Maryland Academy of Audiology sees the audiology assistant position being an extender of the audiologist, helping with routine tasks, freeing up clinical time to allow the audiologist to work to their highest scope of practice. Audiology assistants will improve access to patient care by increasing availability of services and reducing wait times due to increased productivity. They will provide improved access in rural areas of Maryland, like it was mentioned before, where there are a limited number of providers, and in busy clinics or practices that oftentimes have a 3-week or more wait time in order for the patient to be seen for an appointment. Anticipated routine tasks will be delegated by the audiologist and would include duties such as preparing an exam room, equipment and patient for the visit, general instruction, routine cleaning, and basic troubleshooting of hearing devices. They could also assist the audiologist with difficult testing patients, in particular a pediatric patient that comes in and we're having difficulty. They could definitely assist us with that. They wouldn't actually do the testing, but they could definitely help us with that. The economic development impact of this legislation is strong. There are more than 450 licensed audiologists in the state of Maryland. This legislation allows a licensed audiologist to supervise up to 2 audiology assistants, thus allowing for the creation of more than 900 additional jobs in the state of Maryland. Thank you for your time and consideration. Thank you, Senator Lamb, for sponsoring this legislation. We ask for a favorable committee report on SB 379.
Thank you, Dr. Holton. And finally, Candace Robinson from Department of Health with an amendment. Ms. Robinson.
Good afternoon, Chair, Madam Chair and Committee. Dr. Candace Robinson, Executive Director of the Board of Audiologists, Hearing Aid Dispensers and Speech Language Pathologists, and also an audiologist myself. As you have heard from Dr. Senator Lamb, Dr. Spohr, and Dr. Holton, the bill originally asked for audiology assistants to be registered, and we concur that they should be licensed just for the simple fact that they would be held to all of the health occupations, Article 2, held to all the same standards. And the fact that, the audiologist wouldn't always be 100% in the room, and that an assistant could be prepping patients and so forth. We also know that out there are some people serving in these roles inappropriately and using other terms. And this bill would allow only to be called an audiology assistant, and you would have to be licensed. Some of the terms are listed that would not be allowed to be used, and we wanted to add the terms hearing aid technician and cochlear implant technician to make sure that we're protecting our consumers as best as possible. And we respectfully request a favorable report on SB 379 with the requested amendments. Thank you for your consideration.
Questions for the proponents and the proponent with an amendment? Committee, any questions for any of the panelists? Not rushing, but seeing none, that concludes the hearing on Senator Lamb's first bill. Thank you all for your patience and your testimony. We will now move on to Senate Bill 500. Also, Senator Lamb. This bill is interjurisdictional compact. The senator will lead off, followed by Paul Berman, Linda McGee, Mary Alvord, and Christopher Arnold. Then we'll take questions, and then we'll go to one of the opponents, Raj Rosden, who is unfavorable. Senator Lamb, you're back up.
Yep, sure. Thank you. Lamari, if you could pull up the slides for this one too.
Yeah.
And I'll go ahead and get started in the meantime. So good afternoon, members of the committee, chairman, and others. For the record, Clarence Lamb, Senator District 12. So SB 500 deals with establishing an interstate interjurisdictional compact for psychologists. As you may know, psychologists are typically required to be licensed in the state in which they practice. And this includes both in-person treatment and telehealth treatment. In Maryland, the Board of Examiners of Psychologists issues these licenses and investigates any complaints that may be made against these practicing psychologists. This means that a Virginia psychologist can't provide telehealth services to a patient, for example, in Maryland. What, next slide. What SB 500 would do in Maryland is create a compact called PsyPact, P-S-Y-P-A-C-T. PsyPact allows doctoral level psychologists to be approved to practice telehealth into other PsyPact states and allows psychologists to provide short-term in-person treatment to other PsyPact states. It's important to note that many of the states that neighbor Maryland, including DC, Pennsylvania, Delaware, Virginia, and others, are currently members of PsyPact. PsyPact also clearly specifies which state laws supersede, both in terms of scope of practice laws and also patient safety laws, which state laws supersede each other, and how any complaints against psychologists would be investigated. Next slide. So, we often get the question of why should Maryland join this interstate compact? The first reason is really for continuity of care. There are many scenarios, especially in Maryland, in which a psychologist and their patient may live in different states. An example, this could be where a young person might have a psychologist in Maryland, but then go to college in Pennsylvania, or a child who has divorced parents might spend half their time in Virginia and the other half of their time in Maryland. Another example is where a person who's in treatment for substance use might work in DC, but have a psychologist in Maryland. And if they have a crisis when they were at work, they may not be allowed to speak to that psychologist in different jurisdictions. So this bill would help ensure continuity of care really a reflection of our modern kind of interstate medical system. Additionally, SIPAC would help address access to care problems. This is especially important for people living in rural Maryland and for people who might need specialty care. For example, a child with autism living in rural Maryland might really benefit from an appointment with a specialist. And so under SIPAC, if they can't get an appointment with a specialist in Maryland, they could access a whole group of other qualified specialists living in neighboring states. Next slide. If, as you can see from this slide, many states have joined SIPAC and many more are considering legislation to join this interstate compact. Again, highlighting the fact that DC, Pennsylvania, Delaware, and Virginia are all currently members of SIPAC. DC actually formally joined SIPAC in January, and it's also too small to see in this map. So the map is slightly out of date. Next slide. So one other question that often comes up is, would SIPAC allow a psychologist with lesser credentials to practice in Maryland? We believe the answer to this is no. SIPAC has an approval process for psychologists, and the requirements for that process are pretty strict, or stricter than Maryland's own licensing process. Next slide. Another important question centers around patient safety laws, such as reporting suspected child abuse. These laws vary between states, unsurprisingly, but SIPAC clearly specifies that for patient safety laws, the location of the patient is what really matters. Any patients who are living in Maryland will be covered by Maryland's laws, even if their psychologist is located in a different SIPAC state. I do want to note also, because some people might be aware, that there is another bill sponsored by the governor, SB 568, which would allow interstate telehealth practice for all health providers. This is broader than just psychologists. I point out the difference here because the SIPAC legislation accomplishes some important things that the administration's bill does not. Namely, number one, I think if you go to the next slide. Oh, no, I'll go back. So number one, SIPAC clearly establishes how scope of practice and patient safety laws in the states, the different states interact. So it clarifies this. This is important because, as I mentioned a few minutes ago, state laws can vary from one jurisdiction to another. So for example, Maryland has certain laws around how and when a psychologist needs to be able to report suspected child abuse. And under SIPAC, Maryland's laws would supersede even if the psychologist is practicing in a different state. The administration's bill doesn't clearly specify which laws supersede. So in this instance, particularly when it comes to psychologists, it could lead to some confusion. Secondly, SIPAC clearly establishes how complaints against psychologists would be investigated. For telehealth, for example, SIPAC requires that the Board of Examiners of the home state of the psychologist investigate complaints, even if that patient is located in Maryland. So SIPAC would also automatically prohibit any out-of-state psychologists from practicing into Maryland if there were a discipline issue or in any other SIPAC state. In contrast, the other bill just states that our board can refer to out-of-state boards, but makes no mechanism for ensuring that those boards actually investigate the provider. Again, this is important because we don't want there to be confusion around which state's Board of Examiners is supposed to be investigating a certain complaint. And finally, issues of interstate practice have almost always been addressed using interstate compacts because these compacts are profession specific. They can address the unique needs of each profession. Compacts like SIPAC would also allow Maryland providers to practice in other compact states instead of only allowing out-of-state providers to practice in Maryland, which is what the administration's bill accomplishes. I also know that the Board of Examiners has some concerns around this bill. We disagree with their interpretation of some sections of the bill. Our stakeholders and partners have reached out several times to the Board of Examiners to try to discuss their concerns. We have not received a response. So in conclusion, this bill would help address the mental health crisis by providing a way for psychologists to practice telehealth in other states, all while also ensuring proper patient safety. SciPact is currently operating in 14 other states in addition to the District of Columbia, showing that it can be an effective mechanism for increasing access to care. And for these reasons, I urge the favorable report from the committee. With that, let me close and pass along to other members of the panel.
Thank you, Senator Lamb. Let's go to Paul Berman, please.
Thank you, Mr. Chairman, Madam Co-Chairman, members of the committee. My name is Paul Berman. I'm a licensed psychologist in the state of Maryland, practice in Towson. And thank you very much, Senator Lamb, for sponsoring this legislation. So I'm here today to testify in support of Senate Bill 500 on behalf of the Maryland Psychological Association with 1,000 members who are licensed psychologists. I'd like to start by talking about the history and purpose of SciPac, the Interjurisdictional Compact. And it was developed with the assistance of local and national psychological associations beginning back in 2015, practicing psychologists, also consumer groups, the National Governors Association, the Council of State Governments, and the psychological regulatory community. SciPac allows psychologists, doctoral level psychologists only, licensed in their home state, to practice via SciPac in using two methods into other SciPac states. One is via telehealth, and the second is a temporary allowance to be able to practice up to 30 days in another SciPac state. SciPac, again, provides for patient protection by requiring that only doctoral level psychologists be able to practice under SciPac, and certifies that each psychologist applicant is competent to provide services. As Senator Lamb said, you may be hearing from our Board of Examiners of Psychology, which may testify that SciPac 500 or Senate Bill 500 allows non-doctoral level psychologists to practice into Maryland. We disagree with that. And what I would like to do is go to attachment 1, if people are able to access attachment 1. Attachment 1 that I submitted with my written testimony clearly states that the e-passport, which is something we need to get in order to practice under SciPac, the e-passport requires a doctoral degree. In addition, the e-passport requires that the doctoral degree be granted from an American Psychological Association school or a Canadian Psychological Association school, or be certified by the National Register. Exactly the same qualifications as are required by the state of Maryland. Again, my family often says I repeat myself. I will repeat myself. SciPac requires that psychologists be doctoral level and get their degree from an American Psychological Association school or Canadian Psychological Association school, the exact same credentials as are required in Maryland. As Senator Lamb said, Maryland is the only jurisdiction in our region which is not yet included in SciPac. 4 of the 5 states bordering Maryland are members of SciPac. DC just passed it, Virginia, Pennsylvania, Delaware. We understand the 5th state, West Virginia, will be introducing SciPac this year. We know that interstate compacts are being introduced this year into the legislature. We understand that there is another interstate compact on occupational therapy, physical therapy, licensed clinical professional counselors, and of course, SB 500 for licensed psychologists.
Dr. Berman, you're going to have to start wrapping up.
I will wrap up. Thank you very much, Senator Pinsky. The other benefit of the interstate compact is it does specify which laws supersede which laws in the various states, whether it's the home state in which you're practicing from or the distant state in which you're practicing to, and also specifies the authorities of the different licensing boards. We urge you to support Senate Bill 500 and request a favorable recommendation. Thank you very much.
Thank you, Dr. Berman. Let's go to Linda McGee, followed by Mary Alvord, followed by Christopher Arnold. Then we will go to the opponents, Raj Rosden and Christopher Bishop, who I inadvertently left off. Okay, Ms. McGee.
Hi, my name is Linda. Hi, my name is Linda Fleming McGee, and I'm a proud constituent of Delegate Bonnie Collison. I urge you to support SB 500. Interstate practice of psychology is an idea whose time has come. It has come into its own in the midst of a perfect storm. Burgeoning awareness of the absolute necessity of mental health care and the skyrocketing numbers of cases of depression, anxiety, addiction, and suicide. The eye of the storm, COVID-19, further catapulted mental health concerns into the stratosphere, with the federal government reporting record cases of depression and anxiety. Fortunately, the mental health care system has moved toward making therapy more available. Telehealth within state has given way to teletherapy across state lines due to the temporary licenses or exemptions permitted by states, and with the advent of SIPAC in 15 states. Continuity of care for Maryland residents is a paramount concern. The effectiveness of therapy is largely dependent upon establishing a therapeutic relationship and continuing care, even if the client geographically relocates. In my practice, I primarily treat teenagers and college students who regularly leave this area for college. SIPAC would allow me the ability to provide therapy during critical transitions from high school to college, during college and post-college, where relocations are frequent. Likewise, it would allow out-of-state students at Maryland universities to continue their care with their home state therapists. Under current law, if my Silver Spring-based college student goes to Penn State, I'm unable to treat them as I have no license in Pennsylvania. I'm forced to transfer the care of a vulnerable client due to laws made decades ago. COVID-19 gave some temporary respite to provide treatment due to states allowing temporary licenses, but many of these exemptions have expired. The mental health effects of COVID remain and will likely to do so for the foreseeable future. Prior to COVID-19, I was licensed in Maryland and could see clients in my Chevy Chase office, regardless of whether they came from DC or Virginia. In order to see clients in the district in Virginia via telehealth, I was by law required to get a license in both Virginia and DC. This was a very expensive process that involved taking more and different continuing education classes, getting fingerprinted, required a notary, and cost several $100s. These costs are prohibitive in this economic environment and place a heavy hardship on many members of our profession who are already struggling to make ends meet and paying off student debt. Continuity of service would also allow state psychologists to follow their clients who relocate to Maryland. MPA recognizes that there are specialties that may have had more providers for services from out of state. One such example is the dearth of marriage and family therapists in some areas of our state. Likewise, Maryland psychologists may provide specialized services that may be marketable in other states. I provide a lot of court-based educational consultancies in states where I'm licensed, and SIPAC would allow me to branch out. There are two underserved communities that I hold near and dear to my heart: rural areas and communities of color. Being a native of rural Indiana, I know that many areas of Maryland have little access to mental health care. There may be only a few therapists in the area, and oftentimes the mental health professionals either are not a good fit or may not be able to provide a service due to having experience of the specialty needed, or the psychology may have
Ms.
dual.
McGee, you've got to complete your overtime.
Okay, one more thing I want to say. I want to talk about African-American communities of color.
You're already a minute and a half over, ma'am.
All right, one last statement. Thank you.
Ms. McGee, you were muted for the last two sentences. Can you give us those two?
Yes, please. I wanted to just say there are 100 and at max 150 African-American psychologists with over 1.8 million African-Americans in the state of Maryland. The dearth of care is enormous, and we need SIPAC in order to serve our communities of color.
Thank you.
Thank you.
Mary Alvord.
Hello, thank you, Senators. I am Mary Alvord. I have been licensed in Maryland as a psychologist for more than 40 years now. One of my passionate areas is promoting and delivering telehealth services really for well over a decade. And so I'm here from the practitioner standpoint as well. I direct a large practice. One of our offices is in Rockville, very close to Virginia, and our other office is just steps away from DC in Chevy Chase. And so we have been doing telehealth actually pre-pandemic, about 10% to 15% of the practice. And since the beginning of the pandemic, I have now trained about 10,000 mental health professionals in the United States primarily, and some from abroad. So want to talk about how telehealth increases access and how we need to really decrease all of the barriers that we possibly can. One of the biggest barriers is interjurisdictional practice. And as has been said, college students are a vulnerable population. It's something that we struggle with because either we want to help them with transitions during the time that they start college in normal times. And that means that we are trying to get them services perhaps on campus, but they're basically Maryland residents that are going away temporarily. So the transition, sometimes we offer many specialized services like for obsessive compulsive disorder and trichotillomania, specialties that we need the continuity. And so if a student goes to Delaware, we cannot follow them unless we're licensed there. The other thing is we serve many children and teens, and one child might have two homes. In this day and age with the high incidence of separation and divorce, we have parents and a child may end up in another parent's home. And so we need the continuity of care. Many parents also perhaps work in the district or in Virginia and not in Maryland. And so we're trying to coordinate all these appointments so we can maximize.
Dr. Alvord, you have to.
Okay, just one more point, and that is equity.
Briefly.
I feel like the equity is the time for people, especially if they are paid by the hour.
Thank you, Dr. Alvord.
Thank you.
Gentlemen, let me be very clear. We have another 40 or 50 witnesses. And people really have to respect the time limits, okay? Because it hurts people who are following later at 4 o'clock or 5 o'clock. So please, if it's 2.5 minutes, we mean 2.5 minutes, or so let's just be respectful of that.
Thank you. That was my last point. Thank you.
Senator Kagan.
Thank you, Mr. Chairman. I think this might be a question for Senator Lamb. Lamoria, I don't know how hard it is to go to slide 3, or Senator, if you've got easy access to it.
No, not at all. I can pull it up.
That would be awesome. I just want to make sure I saw it right. And Senator, I'm going to ask the question now, but I just want to, I think slide 3 talked about a cap of 30 days of in-person. Slide 3. Nope, that's 7. There we go. Allows licensed doctoral level psychologists to conduct 30 days per year of in-person treatment in other SIPAC states. So hypothetically, I'm going on vacation in Las Vegas and I go and I do 30 days, I have another house there or something. If I do 8 patients a day, am I talking about 240 appointments? Like, is there a cap there? How is a day counted? Is it a work day? Could that be one appointment? Could it be 8? Can you just clarify that for me, please?
Yeah, sure. It is a cap of 30 days. I think the thought, and this is similar to the genetic counselor bill that we heard before too, that it's really just an exception to give people some flexibility to be able to care for their patients while they're, they're out of state, or they're out of state rather.
Coming in and out, if you can get a little closer to the computer. I don't know why. Yeah, sorry.
Sure, sorry.
Yeah.
So, I think it's meant to be an exception. And, I think if someone's practicing more than 30 days out of state, then, it's really intended that they would seek licensure there. This is meant to really be a cap. I don't think are realistically seeing, a patient. These are psychiatric patients. So it would be hard to see that many patients a day. So I think it's really meant to be an exception. And that's why the 30.
Okay, I think it's a good idea, and I loved your examples of whether it was expertise or college kids leaving or extreme, need to have continuity or whatever. So I think it's a good bill. That was just something that caught my eye. So thank you, Senator Lamb. Thank you, Mr. Chairman.
Sure.
We have one more proponent, then we'll go to the opponents. Let's have Christopher Arnold, please.
Thank you, Mr. Chairman. My name is Christopher Arnold. I'm the Northeast Region Liaison for the Department of Defense State Liaison Office, operating under the direction of the Undersecretary of Defense for Personnel and Readiness. And I'm on a couple of panels today, so I'll try to be as brief as practicable. Our mission is to be a resource to state policymakers as they work to address quality of life issues of military families. On behalf of the Department of Defense, we appreciate the opportunity to support the policies outlined in Senate Bill 500. I would like to thank Senators Lamb and Hedelman for their sponsorship. A vote for this bill is a vote to support our troops and our military spouses. Joining the compacts before you today will improve access to care and allow military personnel and spouses to more easily maintain their certifications when relocating. DoD pivoted in its approach towards licensure after 2017 to consider occupational license compacts as another alternative to improve portability for military spouses. Compacts establish common understanding of competency and its measurement within the occupation, and then seek to have states approve the compact through legislation. DoD encourages states to simultaneously fulfill what can be done as far as immediate actions, near-term actions, and long-term solutions, such as interstate licensing compacts. DoD tracks an overall assessment of states based on commitment to these approaches for all occupations. Military spouses are a cross-section of the American population, although a greater percentage of them are in licensed occupations than their civilian counterparts, and they are significantly more mobile. A 2018 study by the Federal Trade Commission recognized that there are two approaches to alleviating barriers to portability, namely mutual recognition, which relates to occupational compacts, and expedited licensure. Compacts can provide seamless reciprocity for military spouses in an occupation. Barriers to the transfer and acceptance of certifications and licenses that occur when state rules differ can have a dramatic and negative effect on the financial well-being of military families. Removing these barriers, creating reciprocity in licensing requirements, and facilitating placement opportunities can help a military family's financial stability, speed the assimilation of a family into its new location, and create a desirable new employee pool for the state. Senate Bill 500, or SIPACT, addresses these licensing issues affecting our service members and their families. SIPACT supports telepractice and temporary practice. This improves access to mental health services for military families while allowing military spouses who are psychologists to sustain a counseling practice through telecommunications in compact states. The coronavirus 2019 pandemic demonstrates that interstate licensure compacts can provide a permanent solution to leverage underutilized medical talent to meet labor shortages in high-need areas. To date, 15 states have joined SIPACT, and 14 states currently have legislation pending in addition to Maryland. SIPACT allows an active duty service member or their spouse to designate a home state where the individual has a current license in good standing.
And thank you, Mr. Arnold.
Home state. Thank you.
Thank you. Okay, let's go to the opposition. Let me reverse the order and have Dr. Bishop followed by Mr. Rasdin.
Good afternoon, Chairperson and members of the committee. My name is Dr. Christopher Bishop. I'm the chair of the Board of Examiner of Psychologists. I am testifying on behalf of the Psychology Board and opposition SB 500. The board has always supported expanding cross access to mental health service to the residents of Maryland. In 2017, telehealth legislation passed, and without hesitation, the board was able to pass those type of laws. We do have several issues with the bill. The education and training requirement to participate in the compact are lower than Maryland requirements to practice psychology. Maryland defines a doctoral degree in psychology as a degree received from a program that at the time the degree was awarded was accredited by the American Psychological Association or the Canadian Psychological Association. The bill does not address that in Articles 4, if you would take a look at it. We cannot assure Marylanders to have receive a safe and effective mental health service without that credential. The compact will place a significant burden on licensee. The compact will cause an inequality in who can afford to be part of the compact. This will result in a limited number of new licensees being able to take on additional financial burden. Furthermore, the board is self-funded and will have to increase fees paid by licensees to pay for complaints and disciplinary processes related to out-of-state psychologists and the imposed fees by the Association of State and Provincial Psychology Board. Another problem with the bill, the compact will exclude psychologists with previous criminal records. The board supports second chances and consider all applicants' backgrounds in granting licensure. As you're aware, the administration is sponsor of HB 732, teleservice by out-of-state practitioners, and the board supports this bill. The administration bill aligns and expands the board current process to allow out-of-state licensees to render services to Maryland temporarily. Also, the administration bill increases access to services, keep the process simple, and does not create financial burden on the board, licensee, or Maryland residents. SIPAC limits access to only states that are part of the compact. The board allowed those from all states to provide telehealth. This concludes my testimony. The board respectfully asks the committee to vote unfavorable for Senate Bill SB 500. Thank you for this opportunity, and I'm happy to answer any questions. I just want to add too about the military. The military and federal government are exempt from these type of laws, so they can practice across state lines.
Thank you. Mr. Rasdin, please.
Good afternoon, Mr. Chairman and members of the committee. My name is Raj Razdan, and I'm a consumer member of the Board of Examiners of Psychologists. I'm testifying in opposition of SB 500, Psychology Compact. The board agrees that expanding access to mental health services to Maryland residents is extremely important. In 2017, when telehealth legislation passed, the board quickly promulgated regulations to implement the telehealth, and this process has been successfully operating. To further its commitment to increase mental health services to Maryland residents, the board is supporting HB 732 telehealth services by out-of-state health practitioners during this legislative session because it expands the telehealth process that the board currently has in place. Two of several significant problems with this bill are the education and the training requirements, as Dr. Bishop has mentioned, to participate in this compact are lower than Maryland's requirements to practice. As a consumer member, I'm concerned that the lessening of the requirements will diminish the quality of services to Maryland's residents. Also, the difference will present an opportunity to circumventing Maryland's requirements. Another problem is that it eliminates second chances for those with a criminal record or adverse action on their license without any due process. The board does not function in this way. The board has never denied an application simply because of one's past. For these reasons and the others stated in our opposition paper, the Psychology Board asks the committee to vote unfavorably for SB 500. Thank you for this opportunity.
Thank you, Mr. Rosden. Questions, Senator Ellis, followed by Senator Washington.
Yeah, thank you, Mr. Chairman, and thank you, Senator Lamb, for this bill. So I just want a clarification. Dr. Christopher, who testified, talked about the DOD already are not bound by the licensure issues. But I think from the DOD, Mr. Christopher, and I can't see your last name, I think he was talking about military spouses, non-DOD officials, individuals who are in the civilian world. So, Mr. Dr. Christopher, did I understand you correctly? And then Mr. Christopher, I can't see your last name. Could you amplify what you were talking
Christopher
about?
Arnold, Senator.
Mr. Christopher Arnold. Okay, thank you.
Yeah, if I was getting clarification, yes. So for licensure, educational and government is exempt from those laws. So if someone's practicing as a military psychologist, they can practice against, they only need a license in one state to practice among all the states. I myself work with the federal government and I'm only required to have one license to be able to work across any state.
Okay, so I understand your point. And Mr. Arnold, could you clarify your major emphasis about the military spouse?
Absolutely, Senator. And in the National Defense Strategy, there are 4 lines of effort. And right after improving lethality, number 2 is improving career opportunities for military spouses. So military spouses are not automatically issued a license. And the reason that we support legislation like this is that removing barriers, creating reciprocity in licensing requirements, and facilitating placement opportunities can help a military family's financial stability, speed the assimilation of a family into a new location, and create a desirable new employee pool for the state, as I indicated.
Right. So the military spouses, to be clear, are not military members. They're not government employees. They're civilians, which would benefit from this, right?
Correct. And DoD has found that SIPACT enhances member states' ability to protect the public's health and safety, especially client patient health and safety, in addition to the benefit of providing portable careers for military spouses.
Okay, thank you.
I had Senator Washington.
Thank you, Chairman. Thank you, Senators, for bringing this bill. It's very interesting, very complex. I think I want to better understand Dr. Bishop's objection. Well, first, I want to say thank you for the observation around the second choice. If you could reference where that, or second chance rather, if you could reference where that is in the bill, I think that would be something that we should look at. But my question is, you said that there was an administration bill or an executive order that extended reciprocity to all 50 states. Is that what I heard you say?
No, what you heard me talk with the board is supporting HB 732, teleservice by out-of-state health practitioners. The board mission is to protect Maryland citizens. That's just what the mission of the board is.
Right.
And so with this bill, it will allow Maryland residents to have more access. Currently, again, the board already has those things in place. That's the Mobility Act that people can practice throughout Maryland. This bill will allow more access from other states for Maryland to receive those services.
So, you're saying, so currently there's no executive order or piece of legislation that extends to the other 49 states?
Correct. The board mission's only focusing on Maryland. So we are looking at how to, for Maryland.
So just for that concern, I would direct you to, and I guess I want to get your understanding of page 17. It's Article 9, and it's quite extensive, and it really lays out what the coordinated licensure information system, and that there is identifying information, licensure, significant it seems like there's a lot of ways in which to check out and ensure that the practitioner in the other state has the qualifications. Could you point out where your specific concerns are and how we might tighten it, or is this not enough?
Right. So again, let's start with just Article 4. You heard for the proponents, they stated that APA and Canadian accreditation required. That is nowhere in the language of this bill. And that's one of Maryland's primary requirements for becoming licensed in Maryland, is that you have to come from an AP accredited or Canadian accredited program. And this bill does not have that language.
So if that language was in the bill, you would withdraw your opposition?
We would consider the whole bill. I mean, there's other issues, but that was a main part of our concerns. Yeah. My understanding is, because we have met with other delegates. I know I heard early Senator Lamb said we did not respond. but we actually did have meetings twice with delegates regarding
Now
with
you're in the
Johnson and
Senate.
Cullison. So that's not true, but yes, but
Well, I mean, we're different bodies and we each handle the legislation separately, so.
correct. I mean, this is people reach out to us.
Thank
so
you,
we reach
though.
back. Yes.
Thank you so much. I look forward to having the conversation. Thank you, Chairman.
Seeing no further questions, that concludes the hearing on this bill. Thank all of you for your patience and your testimony. Senator Lamb, your last one, which seems a lot briefer and a little easier. Well, I hate to say something less complex, but this is on hearing audiologists and hearing aid dispensers, speech language pathologists, duties and appointment of members. We'll hear from Senator Lamb, then from Jennifer Mertes, and then favorable with amendment, Candace Robinson, Dr. Robinson, and there is no opposition signed up. Senator Lamb, please.
Sure. So thank you. So this is Senate Bill 523, State Board Examiners for Audiologists, Hearing, Speech and Language Pathologists. So good afternoon, members of the committee. For the record, Clarence Lamb, Senator District 12. This bill was actually requested by, and we've been working closely with the Board of Examiners to modernize and update their statute. The chair of the board and the executive director are here to go over the bill and to answer any questions. But very briefly, SB 523 seeks to define professions licensed by the board as healthcare professionals. Number two, it also looks to expand the application pool for consumer members of the board. And number three, to update requirements regarding public disclosure for licensure status. Because many of these are fairly technical, I'm going to pause here and then turn it over to other members of the panel and the board to be able to convey the rest of this.
Okay, Jennifer Mertes or Mertz.
Hi, yes, this is Dr. Jennifer Mertes. Thank you so much for having me today. I am in the 4th year of my appointment to serve on the licensing board for audiologists, hearing aid dispensers, and speech language pathologists. And over that course of time, this bill is a summary of some things that we see just need some, housekeeping. And just like Senator Lamb said, thank you, Senator Lamb, for supporting this bill. We appreciate your support. Just as, optometrists and podiatrists and other healthcare professions, it would help us to have our licensed professionals listed as a healthcare profession so that the items in Title I, whenever it refers to a healthcare professional, that those will apply to all of our licensees. And we have seen, some of that pop up in some of the licensing and discipline cases that we review. Another thing that that is in this bill that will help us greatly is for the consumer safety. Right now, we do not have anything that specifies that licensee should practice under their licensed name. So sometimes we have complaints that come in and we have difficulty following up on them because they're practicing under a different name than we have in our files. So it would just help board operations, consumer understanding and safety if they practice under their license name and they provide their license number on all work product that they distribute. Yes, and then clarifying the appointment procedures for consumers on our board. And then also the executive director is going to talk about amendments that were proposed, which the board supports, just clarifying how those appointments are processed as far as not requiring a balloting process due to fiscal concerns, and making sure that the people who would like to serve on the board, it's open to a variety of people, not narrowed down to people within a certain professional organization or consumer organization. So thank you again, and we look forward to your support.
Thank you, Dr. Mertes. Dr. Robinson.
Hello again, Chair and Committee. Thank you again, Dr. Senator Lamb, for your support of this bill. Yes, I would, for the sake of time, I would like to really say me too, because our Chair, Dr. Murtis, has really covered everything. And the two of us have, worked with our local professional organizations to really comb through these statutes and make sure that we are crossing our T's and dotting our I's and making sure that we're relevant in today's society and today's times for all things related to licensing. One of the things that Dr. Murtis mentioned was that we wanted to clarify that we didn't want a balloting process because the cost to ballot every time you want to have an appointment come onto your board is at least $5,000. We currently go through the normal appointment process with the Governor's Office of Appointments, and we get a list of names of people. They have to apply to the Governor's Office, and we look at them and we decide who we want to extend that appointment to or to be vetted based upon diversity. And diversity includes racial diversity, ethical diversity, geography, any subspecialty within their practice, so that we make sure that all of our consumers and professions are well represented throughout the state of Maryland. So we ask for your favorable report with those amendments. And I'm happy to answer any questions.
Okay, are there any questions for Dr. Murtis or for any of the proponents? Seeing none, that concludes the hearing on Senate Bill 523. That concludes that hearing. Madam Vice Chair.
Thank you, Mr. Chairman. The next bill is Senate Bill 516, Senator Klausmeier. This is going to be State Board of Environmental Health Specialists Fees, General Fund. And following Senator Klausmeier will be Bert Nixon, followed by Matt Kumers and James Merrow, and possibly Alex Butler if he's around. And following in the chairman's path, let me just mention that there is no opposition. There's no even favorable with amendments, so you don't need to use your full time. So Senator Klausmeier, welcome to Education, Health, and Environmental Affairs.
Thank you, Madam Vice Chair. Senate Bill 516 eliminates the State Board of Environmental Health Specialists Fund and requires that the State Board be funded through the General Fund. Last year, this committee approved this legislation and it passed the Senate unanimously before we adjourned due to COVID-19. As a reminder, in fiscal 2013, the legislature transferred the board from the Department of the Environment to the Department of Health. As part of that switch, their funding mechanism was switched from the general fund to the specialist fund. Once this change was completed, the board completed a long-term fiscal projection, which showed that if revenues did not increase, the board would run a deficit. Over the past few years, the collecting of licensing fees has proven to be insufficient. By changing the funding from a special fund to the general fund, it would help provide sufficient funding to the board without having to pass those costs on to licensees who have little to no discretion on setting their salaries to recoup licensing fees. I thank the committee for their consideration of Senate Bill 516 and ask for a favorable report.
Thank you very much, Senator Klausmeier, for your brevity and thoroughness. The lead proponent, Bert Nixon from the Maryland Conference of Local Environmental Health Directors. Mr. Nixon, you have up to 5 minutes, but you don't need to use it all. Welcome to EHE.
Yes, since we already passed it last year.
Mr. Nixon, you'll need to unmute and you can start again since we missed the beginning. Or Lamaria, maybe you can help. Mr. Nixon, you are still muted. There you go. Okay.
Can you hear me?
Now
Okay.
we can go.
All right.
No, we lost you again. You're gonna have to try one more time. You want us to come back to you?
All right.
Okay.
Can you
there
hear
go.
me now?
Now we can. Go for it.
All right, very good. Thank you. I'm sorry for the delay here. Madam Vice Chair, Mr. Chair, members of the committee, Bert Nixon, as mentioned, I'm the Director of Environmental Health for Howard County Health Department, also served on the board for 9 years, 3 of which were president. So I'm here today representing both the Conference of Environmental Health Directors and the Board of Environmental Health Specialists in strong support of Senate Bill 516. Senator Klausmeier pretty much covered much of my testimony. So basically, I'll just mention that environmental health specialists do play key roles across the state in a variety of different environmental health-related regulations. We've been very involved this past year due to COVID and addressing a number of the executive orders and dealing with health and business-related concerns statewide, and now doing vaccination clinics. The board provides that key oversight and standardization for us. And yeah, the funding is what's really a concern here. And so we're hoping that the committee here will give us a favorable review. And I want to thank Senator Klausmeier for her support. Thank you.
Thank you, Mr. Nixon. Next up is Matt Kumers with the Maryland Board of Environmental Health Specialists. Mr. Kumers, you have up to 2.5 minutes.
Thank you very much. I greatly appreciate you hearing me, distinguished members of the committee. I make it very brief today. I'm basically second everything that Bert said. I'm here on behalf of the Board of Environmental Health Specialists, and I'm an environmental health specialist myself. Just so you all know who we are, we're also referred to as the health inspectors.
Are there any witnesses for 5, 6, 17?
We are the people who are in the restaurants, in the grocery stores. We're regulating water, wells and sewage disposal systems and pools and a variety of different other health matters and different regulations that we, that we enforce to protect public health. So I just wanted to kind of mention who we are, and that we are generally public sector employees with modest salaries. So the fee increases are substantial if that were to take place, to cover the board's costs. So it's an important bill for all involved there, and health and specialists, environmental health specialists play a very important role. Thank you very much.
Thank you, Mr. Kumers, for your testimony. Next is James Merrow of the Board of Environmental Health Specialists. Welcome, Mr. Merrow. Is Mr. Merrow with us?
Madam Chair, members of the committee.
There we go. We can't see you. And we now can't hear you either. If you can unmute, and if you're able to show your face, we'd love to see you and say hi. And you are still muted. If you can slide open your window maybe and try unmuting. All right, we still don't have you, Mr. Merrow. We don't have audio or visual. Lamoria, is there anything we can do to help him with either one?
See, so I asked him to unmute himself. His video isn't on. He should be showing.
Yeah. Mr. Merrow, why don't you go ahead and try speaking, see if we can hear you, but we still can't see you.
Madam Chair, members of the committee. My name's Jim Merrow, and I'm the Executive Director of the Board of Environmental Health Specialists. And I'm here just to answer any questions that you may have regarding the funding or the operations. That's all. Thank you.
Great. Thank you. Nice to have you here. Alex Butler from the Maryland Association of Counties and colleagues, the Maryland Department of Health has submitted written testimony in favor. So I want to flag that. I see no questions from colleagues, no hands raised. Colleagues have any questions for Senator Klausmeier or any of her witnesses? Seeing none and with no written opposition, thank you, Senator Klausmeier. Thank you, witnesses. That completes the hearing on Senate Bill 516. Thank you for being with us. Next up, Senator Klausmeier. You are here with Senator Bill 517, State Board of Physical Therapy Examiners, temporary licenses to practice physical therapy and limited physical therapy. Welcome again, Senator Klausmeier.
Okay, thank you, Madam Vice Chair, Senate Bill 517 allows the State Board of Physical Therapy Examiners to issue temporary licenses to practice while the applicants are waiting to take their national licensure exam. Physical therapists and physical therapist assistants are required to complete educational requirements and obtain their license in order to practice. Because the exam for the national license is no longer a rolling exam, the applicants may be forced to wait 6 to 12 weeks in order to get licensed. Passing this legislation would allow applicants to practice under direct supervision as they await their testing date, which allows them to earn an income and maintain competence during this time frame. With me today, I have E.Jen Wolford, who is a member of the board, to explain the importance of allowing the board to issue this temporary license. I thank the committee for their consideration of Senate Bill 517 and ask for a favorable report.
Thank you, Senator Klausmeier. And Jean Wolford with the Maryland Board of Physical Therapy Examiners. Welcome back.
Thank you. Thank you very much. Good afternoon, and thank you, Madam Vice Chair, Mr. Chair, and members of the committee. My name is Jean Wolford, and I'm the Physical Therapist Assistant Board member of the Maryland Board of Physical Therapy Examiners. I'm here to support the Senate Bill 517, which purpose is to authorize the Maryland State Board of Physical Therapy Examiners to issue the temporary license to PTs and PTAs who have completed their education and are awaiting to sit for their national licensure exam. The board heard concerns and saw a growing need for temporary licensure, especially during this current pandemic. The Maryland Physical Therapy Practice Act previously allowed temporary licenses when the national licensure exam was provided on a fixed date schedule of 4 times per year. In 2008, the national licensure exam moved to a rolling schedule, and then the need for the temporary licenses were no longer needed. However, in 2010, there was a national exam security breach, and the rolling schedule was discontinued and returned to a fixed schedule. Due to this change, the students are getting temporary licenses to practice in bordering states such as DC and Pennsylvania. In 2020, due to the pandemic, testing centers closed and exams were not being administered. And this furthered the board's discussion to seek the reinstatement of the temporary licensures due to the growing gap between graduation and licensure here in Maryland. The temporary licenses will enable the students who have graduated to be hired to practice and provide patient care after they've completed their didactic and clinical education. It bridges the gap for physical therapists and physical therapist assistants to be licensed, which is needed before they can practice in any capacity in the state of Maryland. For these reasons, the board respectfully requests a favorable decision on Senate Bill 517. Thank you for your time and consideration.
Thank you very much, Ms. Wolford. There is additional written testimony, including from the American Physical Therapy Association and the Maryland Department of Health, both favorable. Are there any questions for Ms. Wolford or Senator Klausmeier? Seeing none, that completes the hearing on Senate Bill 517. Thank you. The next bill, and I think that completes your visit to Senator Klausmeier. So the next up is Senator Hershey, Senate Bill 537. Pharmacists required notification and authorized substitution, lower cost drug or device product. Senator Hershey, welcome back to Education, Health, and Environmental Affairs.
Thank you very much, Madam Chair. For the record, Senator Steve Hershey here to present Senate Bill 537. The General Assembly has sought many ways to lower out-of-pocket prescription drug costs. A few years ago, we removed the gag rule that prohibited pharmacists from telling patients there were lower-cost generic options. Senate Bill 537 will help lower the out-of-pocket costs patients spend on their prescription drugs, reduce prescription drug abandonment, and help patients adhere to their treatment plans and ensure continuity of care. Under current law, unless a provider indicates that a therapy must be dispensed as prescribed or written, a pharmacist may substitute a lower cost generic drug in place of a higher cost brand drug. Pharmacists may also substitute a lower cost generic drug for a higher cost generic drug that is therapeutically equivalent. Part 1 of this bill on page 2 simply expands this disclosure to inform a patient that a therapeutically equivalent brand name drug is available as a lower cost alternative. Part 2, beginning on page 3, authorizes the pharmacist to make the substitution, again, unless the provider indicates that a therapy must be dispensed as prescribed or written. It is important to know that this substitution may only be generic to generic, generic to brand, but not brand to brand. This substitution may also only take place if the uninsured customer is charged less. If the customer has prescription drug coverage, then the lower cost determination must be based on the consumer's prescription drug benefit and formulary. And Madam Chair, I have amendments that have been offered to the committee already. Not the technical, but the second part of the second amendment will state after that formulary if that information is readily available. Amendment, the first part of the second amendment is in the section where the substitution is made. And if that substitution is made, the pharmacist must notify the patient in writing, or again, as the amendment says, or maintain a record that the patient has been notified that the drug or device product has been made, that change has been made. They want that information to be recognized. As amended, this bill has the support of the Board of Pharmacy, MedCai, the chain store drug retailers, Blue Cross Blue Shield, and Kaiser Permanente. In closing, Madam Chair, it is important to recognize that the increased out-of-pocket costs are a driving factor for prescription drug abandonment and increased hospitalizations. A recent survey of 1,000 patients revealed that 75% received a prescription that cost more than expected, and half did not pick up a prescription because of cost. We feel that giving patients the option of lower drug costs that are therapeutically equivalent will reduce prescription drug abandonment and lower overall costs on our healthcare system. I respectfully request a favorable report on Senate Bill 537. Thank you.
Thank you, Senator Hershey. We have a couple of witnesses and then we will take questions if you're able to stick around.
Of course, thank you.
Thank you. Kaylee Locklear from the Maryland Retailers Association. Welcome, Ms. Locklear. Is she with us? She may not be in the...
I do not see her. I thought she was there initially, but I don't see her now.
Why don't we give her another minute? We'll pivot to the second witness and see if she's able to join us. Allison Taylor from Kaiser Permanente. Is Ms. Taylor here? I'm not sure that I'm seeing her either. So why don't we kill a little bit of time, Senator Hershey, if it's okay, see if either of them join us. In the meantime, we do have two senators with questions, if that's okay, or do you want to, is that all right with you?
I'll try my best.
All right, try your best. Oh, then I got to come up with some real zingers. My question, if it's okay, Senator Ellis, do you mind if I go or do you want to go first? Okay, my question, Senator Hershey, did you happen to see the testimony, the opposition testimony from the Attorney General's office?
Of course I did.
All right.
So same opposition was written in the House. By the way, I just received a message from Delegate Shetty saying that the bill passed unanimously in the HGO subcommittee this morning. The opposition from the General Assembly or the Attorney General's office, we all believe is because the writer of that believes that this bill dealt with brand to brand substitution. This bill specifically does not allow that. She also references the FDA's what we call the Orange Book, which is the database that shows the therapeutically equivalent drugs and how they are matched together and how they can be substituted. But specifically, again, it is reading the letter. We believe that she believes that there is brand to brand when that's not allowed.
Thank you, Senator. And we can also connect with counsel and just make sure that we can clarify that.
That's
Ms.
fine.
Locklear, welcome. We're glad you're here. I've already announced you, so I'm glad you were able to make it. Welcome to EHE. You may begin.
Thank you, Madam Vice Chair and honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Chain Drugstore Association. We are here in support of this bill. We've spent a couple years working on it on the House side. And I just want to state that we are fully in support of consumers obtaining the lowest cost drugs. And I think Senator Hershey just touched on this a little bit. The bill did pass unanimously out of the House last year. We ran out of time in the Senate. A couple of things have come up in the meantime that he referenced that I certainly can address. I do very quickly want to touch a little more on the Orange Book, though. So that is an FDA publication that's updated on a monthly basis that contains therapeutic equivalent evaluations for prescribed drugs. And they can only be substituted with the full expectation that the substituted product will produce the same clinical effect and has the same safety profile. And then there are 3 criteria that must be met. So when we saw the Attorney General's letter stating that this bill is not workable, I just want to make clear to the committee that the FDA absolutely does recognize equivalence for generic to brand, brand to generic, and generic to generic. And that is what this bill covers. It doesn't have brand to brand. So we urge a favorable report. I'm glad to answer any questions about therapeutic equivalence and have some more detail for you if you'd like that.
Thank you, Ms. Locklear. We were going to save all the hard questions for Senator Hershey before you got here, but you showed up just in time to protect him. Senator had a question. Senator Ellis, please.
Thank you, Madam Vice Chair. I had like 3 questions, but you brought up one of them about the Attorney General's opinion, that letter. But I have a question for Senator Hershey. I'm going to ask it the exact same way he asked me a question when I presented a bill in Finance Committee last week. Where did you get this idea from? You just made it up?
I don't think that's how I asked you that question. I did ask you if you had gone through the procedure of the Maryland Department of Transportation, but no.
Procedures. I'm coming up with this bill.
Very good question, Senator. I would say, as I started off by saying, we have done a lot in the General Assembly to find ways to lower out-of-cost expenses. And as recently said, this is just expanding that to include the opportunity. And Medkai's letter even says, it could be a rare opportunity where a brand name drug could be cheaper than a generic drug. So we're just widening those opportunities for substitution, staying within the FDA guidelines, and hoping to drive down out-of-pocket costs for patients.
Yeah. Well, thank you for that serious
thank you.
Answer to a joking question.
I understand. Anyway, thank you.
First topic. And so the thing is, going back, I want to delve a little deeper in the Attorney General's opinion, saying that this would kind of just a cost issue. Really, it's not a patient-friendly issue. I just want to know if pharmacists should get into this decision making. So we go to our doctors have the medical training, they understand the patient's unique needs. And so do we want pharmacists, we're giving them more and more responsibilities. The right to do more vaccinations of biological, all kind of duties. And now with COVID, they're doing vaccinations for COVID and, for the flu shots and, shingles, all these things. Do we want them to be analyzing prescriptions also and to communicate with patients, reach out to patients and educate patients? I mean, do you think that is a really, and then of course, cutting out the doctor out of the decision making with patient's unique status. Do you think that would serve the patients well?
Well, Senator, what we want to make sure that we are trying to prevent as much as possible is drug abandonment of patients going to pharmacists and not being able to afford their drugs. What we do want to make sure that we can do as much as possible is make sure that patients adhere to the treatment plans. To answer your question about are we taking any authority away from the prescribers or the doctors, keep in mind that none of these substitutions can be made if the prescriber specifically writes that the substitutions cannot be made, or in a sense, what their terminology is must be dispensed as prescribed or written. So if a provider thinks that that is critically important, they would write that on the prescription, and then the pharmacist could make no changes. But again, the important part of this is being able to make sure that we can lower out-of-pocket expenses and have patients be on the drug treatment plans that they need to be on.
Okay, that sounds good. Thank you, Senator. I appreciate it.
Thank you, sir.
Thank you, Senator Ellis. Senator Carozza.
Thank you, Madam Vice Chair, Senator Hershey, and Kaylee, good to see you. My question is going right to the role of the pharmacist here. We know that our pharmacists are often kind of the front line of many of our constituents.
Can you do me a favor, please? I have some.
Lamoria. There you go. Go ahead.
I'll proceed. Anyway, going back to the pharmacist and Senator Hershey, I'm trying to just kind of bottom line it for our pharmacists because they're often the front lines with many of our constituents with all of our healthcare shortages. Just when a patient or a customer walks into that pharmacy, can you just kind of walk through that exchange, what the pharmacist can and can't do?
Can I ask Kaylee to answer that?
Sure.
Thank you.
Yeah, absolutely. So I think where I would like to start is that pharmacists are medication experts, right? But allowing us to practice at the top of our license involves many of the things that Senator Ellis referenced. And yes, pharmacy is immunizing for COVID right now. We immunize for flu and all types of things for adult immunizations, and then currently need a prescription for minors and permission, of course. But this is all within the doctorate of pharmacy that they receive in this field. And so when a patient comes in and asks a pharmacist for specific medication information, we can give that to them along with a wide variety of things that this committee and the legislature has passed and allow us to do within scope of practice. So we really are on the front lines. We're the most visible healthcare provider available to patients.
Yeah, and Kaylee, where I was going with this, like specifically with this bill, it allows the pharmacist to, I think, give options to the patient. Is that, I mean, as far as this actual bill, is that correct?
That is absolutely correct. So a patient would be able to find out what the lowest cost drug option is for them. And Senator Hershey talked about it a little bit, but we cannot just make some type of brand-to-brand substitution. That cannot occur. These are just for therapeutically equivalent drugs that a pharmacist can make this substitution.
Thank you. Thank you, Madam Vice Chair. I always like to know on the front lines how it's going to work.
Thank you, Senator Carozza. I see no other questions from colleagues. Okay, no hands up. Let me just thank Senator Hershey and the witnesses. I don't see Allison Taylor here from Kaiser Permanente yet, so we have her written testimony as well as written testimony from the Department of Health and the Board of Pharmacy, Board of Physicians, from the Baltimore Jewish Council, the Montgomery Women's Democratic Club, Angela Brooks, the Prince George's County Executive submitted written, and I already flagged the Attorney General's opposition testimony for your consideration. With that, that completes the hearing on Senate Bill 537. Thank you, Senator Hershey. And the next bill.
Thank you, Madam Chair. Thank you, committee.
Next bill is Senate Bill 568 from the President, healthcare practitioners, telehealth, out-of-state healthcare practitioners. Presenting the bill.
Mr. Whitaker, Senator Kagan.
Okay, Jake Whitaker. Yes, there we go. Okay, so the president did the courtesy of putting in the bill. Thank you. I was like, okay, for the governor's office. Mr. Whitaker, nice to see you again. Welcome to Education, Health, and Environmental Affairs. You may begin.
Good to see you as well, Madam Vice Chair, Mr. Chair, members of the committee. My name is Jake Whitaker. I'm with the governor's legislative office here to testify in support of Senate Bill 568. Since taking office, the governor and lieutenant governor have remained committed to addressing the heroin and opioid epidemic, including expanding access and reducing barriers to critical behavioral health and substance use disorder services. This bill allows out-of-state practitioners to provide healthcare services to Marylanders via telehealth. Prior to the pandemic, the lack of available healthcare practitioners presented a barrier to accessing quality services. And we think that this barrier is only going to increase with the COVID-19 pandemic and the increased demand for services. To be clear, this bill is not intended to undermine or interfere with any of the interstate compacts. If anything, it's meant to supplement some of that work. So, for example, the Board of Physicians has an interstate compact, but neighboring states like Delaware and Virginia are not participating. So we feel like this is a way to kind of increase access to some of the different licensees from those states. What we're trying to do is just simply create a pathway for those providers in those states that don't have access to those compacts. And I think to Senator Lamb's point earlier, I think that is important. We do need to hold those out-of-state licensees accountable. We can't make other states do anything, including participate in the compacts, but what we can do is preclude them from practicing in Maryland. And I think this bill gives those boards the appropriate tools to be able to preclude those services. Like I said before, we applaud Senator Lamb in advancing interstate compact bills, as well as the different boards who have already done this. In fact, one of our administration bills this year is an interstate compact for the Board of Professional Counselors. We think Maryland can be a leader in maximizing the number of licensees available to Marylanders by supplementing the interstate compacts that are in place or are moving forward. And for these reasons, we respectfully request a favorable report for Senate Bill 568. And if okay with you, Madam Chair, I'd like to cede the rest of my time to Dr. Jones.
Okay. Aaliyah Jones, the Maryland Department of Health. Welcome to EHE. You may begin.
Thank you so much. This is Dr. Aaliyah Jones, Deputy Secretary of the Behavioral Health Administration. I'm here to testify in support of Senate Bill 568, Health Practitioners, Telehealth, Out-of-State Healthcare Practitioners. These providers are seeking to provide health services through telehealth to Maryland residents abiding by all laws regarding confidentiality of health information and patients' rights applicable in the state. In March 2017, the National Council of Behavioral Health released a report compiled by a 27-member panel of experts drawn by providers, payers, government agencies, and psychiatric associations. That report indicated that there is a national shortage of psychiatrists, with 77% of United States counties reporting a severe psychiatrist shortage. According to this report, the pool of psychiatrists working with the public sector and insured populations declined by 10% from 2003 to 2013. And as we know, there has been no great influx of psychiatrists since that time. Among many other recommendations, they note that we can improve the efficiency of delivering psychiatric services by expanding telepsychiatry and by reducing regulatory barriers. This bill would in effect provide for expansion of services by improving patient access to healthcare practitioners in communities experiencing a healthcare practitioner shortage. Passage would lead to the possibility for more ready access to care, more time to deliver care to vulnerable populations with complex behavioral health needs, more time to collaborate with other healthcare providers for coordination of care, improved ability to refer complicated patients to specialty care, and increased desire to recognize and diagnose behavioral conditions in non-behavioral health settings, which is a barrier that many non-behavioral health providers have when it comes to diagnosing behavioral conditions in their patients. Passage of this legislation would make it easier for consumers of specialty behavioral health services to access providers and treatments not available in the state of Maryland, like access to the Amen clinics in Northern Virginia. The Amen clinic uses a non-traditional psychiatric model using SPECT brain imaging. This passage of this legislation would allow for a consumer to go to their local hospital's nuclear medicine department to do a special scan and then have treatment with a provider at Amen from the comfort of their home, rather than having to drive to Northern Virginia for their care, which may not be possible. Or you can get treatment for severe borderline personality disorder with the experts of dialectical behavioral therapy in Washington State. For the aforementioned reasons, the Maryland Department of Health respectfully requests a favorable report on SB 568 so that all Marylanders can access the care that they need most conveniently, and we would be happy to answer any questions.
Thank you, Ms. Jones. Thank you for your testimony. We have two more witnesses from the Department of Health. Both of them are favorable with amendments. Candace Robinson, you have up to 2.5 minutes. Welcome to EHE.
Thank you, Madam Chair and committee. And I want to just take a moment and thank Jake Whitaker for giving some clarification on what the intent of this bill is. The Maryland Board of Audiologists, Hearing Aid Dispensers, and Audiologists supports the premise of SB 568, which aims to increase access to healthcare through telehealth services for consumers in Maryland. It addresses this by allowing out-of-state practitioners to provide telehealth by becoming registered practitioners rather than becoming licensed. And our board currently licenses practitioners who are out of state and they want to come into the state and provide telehealth. The board is very aware of access issues to provide care through telehealth by out-of-state providers, particularly continuity of care issues due to the displacement of individuals into Maryland during the current pandemic. The board has recently issued support to implement and join the Audiology and Speech Language Pathology Interstate Compact, SB 183 and HB 288, which will circumvent these issues and allow for licensing of out-of-state practitioners who do wish to be a part of that compact. Further, the compact requires that all states who enter into it and all practitioners who wish to be a part of it have equal entry level requirements for practice, whereas registrants from states that are not part of the compact may have lower standards to enter into practice. The compact also allows for practitioners to become licensed in a significantly reduced amount of time, which already licensed through a home state that is part of the compact, if they are part of this compact. So the board believes that it's a duplicative process of the compact, and by virtue of not requiring licensure may open up the opportunity for looser adherence to the laws of the health occupations, which ultimately may be a concern for the protection of consumers of Maryland. Accordingly, the board supports the goal of SB 568, but it respectfully requests that it's amended to clarify that our board is not part of this bill.
Thank you, Ms. Robinson. Thank you for your testimony and for coming in just under your time. If you have suggested amendments and want to send them to committee council, that would be helpful when and if this bill comes up before our committee for a vote.
Yes, and they are in my written testimony.
Excellent.
The two amendments. Thank you.
Thank you very much. Wrapping up the proponents and other favorable with amendment is Lorraine Smith from the Maryland Department of Health. Ms. Smith, welcome to EHE.
Thank you. Good afternoon, Chairperson and members of the committee. My name is Lorraine Smith, and I'm the Executive Director of the Board of Examiners of Psychologists. I am testifying on behalf of the board in support of Senate Bill 568 with one amendment. You should have received the board's position paper. Hopefully you have. If you're not, I'll make sure you receive it because it provides more detail than I will provide you here. This bill, as you know, it authorizes out-of-state licensed psychologists to provide telehealth services to patients located in Maryland and requires the board to register these out-of-state providers. The board supports this bill because it expands the telehealth program that the board currently has in place. Currently, we actually have a temporary exception to practice program that allows, again, those from out of state to provide services in Maryland to Maryland residents. And we expanded that program due to COVID-19, and that expansion included allowing licensees from other states to practice for longer periods of time, whereas our temporary one is just that, it's temporary. In addition, in addition to allowing those from out of state to come to Maryland provide services through telehealth, we also offer have a mobility program. And this mobility program allows licensees from other states who hold a license that meet our requirements and to get an expedited license, meaning they have this certification and they can expedite license, meaning they could be licensed in short as 2 weeks. And these are people who want to provide Maryland residents services on a long-term basis and in person as well as telehealth. So it's both. They can do it that way as well. The board also supports this bill because it does not limit participation based on if a provider is a part of a compact. It can be from all 50 states, anywhere in the 50 states, you can actually provide services in Maryland via telehealth. So that's another reason. And the fact that it does not provide a financial burden on the patient, licensees, nor the board. So it's for these reasons that the board actually supports 568, and we ask that you vote in favor. I'm sorry, there's one other thing. We do have one amendment. I'm sorry, I almost forgot the main part, the amendment.
Okay, but you have to go fast, Ms. Smith.
Okay, all right, real quick. So the amendment is the board's just concerned that since some states have different requirements for licensure, that the board is asking that you insert on page 3, line 9, after the word practitioner, that the word that you insert become licensed, certified, or authorized by law to provide healthcare services in the other state under requirements substantially equal to the licensing requirements established by the appropriate health occupations board in this state.
Thank you, Ms. Smith. Okay, and I assume we've got that with your testimony. There is a lot of testimony on this bill, and unfortunately, there did not seem to be one amalgamated entry in our system the way there often is. So I don't know, Lamoria, if that's fixable, if that's an Office of Information System issue or what, but it can be fixed. We do have questions from colleagues, and then we have a bunch of unfavorable testimonies. So let's start with questions. Senator Croza, followed by Senator Lamb. Senator
Thank you,
Croza.
Madam Vice Chair, and Mr. Whitaker, as the sponsor of the Occupational Therapy Compact legislation, I just wanted to follow up on that because the members of the association have worked, for the past 9 months on this compact. And as a senator that represents a border state with Delaware to the north of my district and Virginia to the south, I certainly appreciate the intent of what we're trying to accomplish, but want to just, if you could just clarify again that our efforts with the OT compact bill, which does not have any oppositions, worked very hard to get the support across the board, you do not see that this legislation would affect that compact. Can you just clarify that, please?
Yeah, absolutely. Thank you, Senator, for advancing interstate compact bill. We think that's the optimal way to move forward. This is meant to supplement the interstate compact. So although we love that the different boards are participating in compacts, we can't ask other states to participate. So we feel like this is an avenue for licensees from those states that aren't participating to be able to provide those services to Marylanders. So it by no means gets in the way of the compacts or interferes with them. We just want to make sure that the licensees in those states that don't participate have an avenue and a pathway forward to provide services for Maryland patients.
You're good, Senator Croza? Thank you very much. Senator Lamb?
Thank you, Senator Kagan. I have some reservations, I guess, about this bill. This bill does a lot, and there's a lot to unpackage here. It seems to, in some ways, kind of undermine a lot of the work that's gone on in the past in developing interstate compacts for individual healthcare professions. And there's been a lot of work that's been going into these compacts to clearly figure out how to address licensing laws in multiple states and how they end up interacting. Potentially the biggest issue with this bill is that after a provider has been registered, the provider is expected to notify the board of any disciplinary measures in their home state, whereas most compacts use an automatic process to actually notify all states within the compact of any disciplinary measures. concerned about the safety issues here, and how are Maryland boards going to make sure that providers keep them up to date on out-of-state disciplinary issues?
Sure, thank you for that question. First, I'd like to say I'd be happy to work with any boards or stakeholders to make sure that we address some of those safety questions. I think we all share the same goal, which is increasing access to these services. I think there's a few different mechanisms through this bill by which the different boards can account for patient safety. One of those is a criminal background check, the registration process, as well as the board's abilities to make sure that they're in good standing with their respective licensing entities in other states. Additionally, if the person is found to be in bad standing, or if there's any criminal records issues, the board can revoke that registration and that person cannot perform services to Marylanders. So although we would love for the states not participating in the compacts to kind of join in and help facilitate that flow of information, we feel like there's appropriate steps to make sure that we protect Marylanders by making sure we can revoke that registration.
So with all due respect, I mean, so what you're saying is that, you know, the individual member who's, you know, going to be practicing the state using this would notify us, or the boards would do a background check, which they normally do anyway, but that's a single point check in time, right? That someone who violates something or practices unethically after the background check is initially done is already past that point. And it's not as though they're doing repeated background checks on a frequent basis to be able to follow up on this. You know, I am concerned about the safety issues here. That doesn't, to me, doesn't quite cut it to have the level of awareness, particularly when the existing type compacts that are in place automatically notify all of the stakeholder states within that compact of any concerns. This is really reliant on kind of a half-baked method of hopefully catching, you know, these instances and then notifying people properly, and, you know, relying on background checks that may or may not catch things depending on when they're actually being done. So, you know, I understand what you're saying, but I don't, to me, that doesn't seem to quite rely on or provide enough reassurance on the safety aspect of it. My second question is, and I appreciate the point that we can't force other states to join compacts, but one of the reasons that states may not want to join certain compacts is because they require certain patient protections that some states may not be ready to take on. For example, the bill that, you know, I presented earlier on the psychology compact requires that a home state investigate a complaint referred to them by another compact state. This bill says that a Maryland Health Board may refer a complaint to another state, but doesn't require the other state to investigate the complaint. I guess Maryland consumers be assured that these complaints are being fully investigated. And how do you address the fact that, you know, multiple boards have come up before this committee and have said that they are overworked and unable to take on more responsibilities, and yet this would require them to proactively reach out to all these other states or to try to solicit these complaints coming in to address any safety concerns that they have?
Can I answer that?
It seems to contradict.
May I answer?
Ms. Smith, you can answer that too, because I think you had opposed the earlier psychology compact bill, but now you're coming forward with this.
Well, in answering your question in terms of the safety, all boards, all professional boards, we are responsible and required to actually report any malpractice or any disciplinary practices to the National Practitioners Database. And every state has access to that. That is a requirement of all states. So any reprimands that may have happened or any violations to any of the laws, by law, boards report that to the National Practitioners Data Bank. And so all boards have that, and you can actually sign up to get a reminder or to get a hit if one of your licensees actually something comes up. So that system is already in place. That's what we do currently.
Colleagues.
And can someone speak to the
Sure, and to speak to your first question, Senator Lang, the bill would require the out-of-state licensee to register periodically every 2 years. So it's not just a one and done situation where they could be in good standing, register, start providing services, then a year or 3 years later they're in bad standing and there's no recourse or way to make that determination. So there is a periodic registration process.
I'm concerned that this bill doesn't require the home states to do anything. The compacts do. Compacts both states to be able to do something.
I make a quick comment?
So I'm trying to move things forward a little bit. I want there to be a
Okay.
good dialogue, but go ahead, Ms. Robinson, very briefly.
Sorry. Yeah, so I think that along with what Dr. Senator Lamb is saying is where our concerns that we require people already. If they want to come in and provide telehealth, we are requiring them to be licensed, and we don't want any loopholes that somebody can pay less money, provide the same services, yet the boards have to use the same resources. And there's a loophole, you know, for them not having to necessarily follow all of the health occupations and be accountable the same way as a licensee when they can be part of this compact. And if they're not, they could just get licensed. Thank you.
Okay. Senator Lamb, are you good? Can we move on to the opposition?
Yeah, I'm good. I'm just concerned that, you know, every time we ask the boards to do something, they say that they don't have the bandwidth to do that. But this bill seems to open up a huge amount of effort required for these boards.
Okay. Well, I think we might hear that from some of the opponents. So why don't we pivot to that? And then if you or colleagues have other questions, we can go to them. I just want to flag for colleagues that in addition to the opposition, we have 3 more bills today, and those of us who are on the cybersecurity subcommittee or work group or whatever with Senator Hester are still meeting after this. So we still have many hours before we sleep here. So let's move on to the opposition. And again, there were more proponents and more opponents, a lot of both on that. So Steve Wise, followed by Robin Elliott. Mr. Wise, representing MedChi, MDACEP, MDAAP, and MDACOG. And I suspect he's going to take half his time translating all of those acronyms. Mr. Wise, welcome to EHE.
Thank you very much. I'll shorten those to say that's the emergency room docs, the pediatricians, and the OBGYNs, all of which are opposed to this. And thank you for the opportunity to speak on this. I would note that it was just in 2018 that this state entered the physician licensure compact, the interstate medical compact. And while it was noted in the proponent's testimony that 2 of our surrounding states have entered that but haven't implemented it yet, I think you have to keep in mind that the compact is relatively new. There are 25 states on board, but others are coming online. When MedChi supported the compact, it was with the notion that that would be the methodology by which an out-of-state physician could become licensed more easily in Maryland. And we think this bill sort of sets up a dichotomy that doesn't need to exist and sets up 2 processes rather than 1. The timing of getting licensed through the compact is relatively efficient. My understanding is that can take anywhere from 10 days to 2 weeks, which is pretty fast considering how licensure for physicians normally takes. The disciplinary issues have been discussed. Clearly, the compact is the better methodology for that. The other thing that I would mention is this legislation does not have any mechanism for reciprocity. So a out-of-state doctor can easily come into Maryland, but there's no requirement that that other state recognize a Maryland physician in the same fashion. The compacts squarely address that issue. So with that, I appreciate your time and I'm happy to answer any questions.
Thank you, Mr. Wise, for your brevity and your testimony. Robin Elliott with the Maryland Nurses Association. Welcome, Ms. Elliott.
Good afternoon. I'm here today representing the Maryland Nurses Association. Our firm also works with the professional associations for occupational therapists, social workers, and professional counselors. All have very similar concerns. The underlying issue that we have is patient safety. And as you've heard before, it is very difficult for a Maryland board to pursue a disciplinary action for a provider out of state outside of a compact. There's just not the same legal remedies. Compacts are definitely, we think, a better model. You have, of course, 4 compact bills in front of you. You heard a couple today. You've heard the occupational therapy compact that we're working on a few weeks ago. Those compacts are worked out over a period of a couple years. where boards across state lines are cooperating on disciplinary licensure models. So they're great models. They're very intricate and well developed. You already have 3 compacts on the books, physicians, nursing, and physical therapists. And I understand that the the Council of State Governments, which puts together a lot of the compacts, has up to 8 more in the works. So hopefully all those 8 bills won't come in 1 year. But I think you will be seeing compact bills every year for the next few years. And we believe they're the better model. Thank you.
Thank you, Ms. Elliott. Colleagues, Senator Lamb in particular, since you had questions before, any questions here for the opponents? Are you good?
Good. I think voiced them earlier. It seems like they also brought up some similar concerns. Thank you.
Okay, good. Colleagues, any other questions? Seeing none, I want to encourage you to look at the hearing testimony. I'm not going to read them all, but I assure you there are very many entries. It's a thick folder, so take a look at that. And that completes the hearing on Senate Bill 568. The next bill is Senate Bill 571, which is also an administration bill. That's Interstate Licensed Professional Counselors Compact. We're doing a lot of compacts here. I could say that we would powder over it, but that seems like a stretch in a pun. So I think we are going to be led off once again by Jake Whitaker with the governor's office. Mr. Whitaker, welcome back. You may begin.
Great. Thank you, Madam Vice Chair, Mr. Chair, members of the committee. For the record, my name is Jake Whitaker with the governor's legislative office, here to testify in support of Senate Bill 571. This bill is also part of the governor and lieutenant governor's commitment to addressing the opioid epidemic by increasing the number of professional counselors available to Marylanders. This compact preserves the authority of each of the member state boards by allowing them to kind of work within the existing Maryland regulatory and statutory structure. The bill also allows the board to continue to determine the requirements for licensure, as well as maintain the unique scope of practice for counselors in Maryland. To utilize this compact, a professional counselor must have a license in good standing with their home state, which is their primary state of residence, and the home state must be a member of the compact. Senate Bill 571 also contains provisions requiring minimum education and licensure and testing requirements to make sure that if a state that has extremely lax educational or licensure requirements doesn't participate in the compact until they raise those standards. I also want to point the committee to our amendment. We consulted with stakeholders and they said, look, the need for additional counselors is immediate. We have counselors in other states that can help provide substance use disorder services now. And so we respectfully request to make this bill an emergency bill. And just in summary, this bill will reduce barriers and improve access to professional counseling services. It will also increase choice for professional counselors for Marylanders. And I think this bill also helps protect patient safety by ensuring that all adverse actions and disciplinary sanctions are reported promptly and shared with the different member states. It also facilitates sharing that information, and it requires background checks. So for the aforementioned reasons, we respectfully request a favorable report with our amendment for Senate Bill 571. And if okay with you, Madam Vice Chair, can I turn it over to Dr. Jones?
You may.
Great, thank you.
You said Dr. Jones, not Dr. Johnson. Yes.
Dr. Jones, that's correct.
Leah Jones, yes. Okay, Ms. Jones, please.
So again, I'm testifying in support of Senate Bill 571, the Interstate Licensed Professional Counselors Compact, which would allow licensed professional counselors to enter in an interstate compact and practice in participating states. This initiative seeks to eliminate barriers to interstate professional counseling practice, improve patient access to professional counseling services, and enhance public protection through a shared interstate licensure data system. Different states have different standards for licensing. This compact would allow Maryland to maintain some quality control over who can provide services in our state, as we would determine the licensure requirements and maintain Maryland's unique scope of practice for all Maryland professional counselors practicing. If passed, this legislation would have several benefits, including but not limited to improving the continuity of care for individuals traveling or relocating to and from other parts of the country to Maryland, improving access to mental health care for populations such as students, active duty military and their families if they're seeing civilian providers, eliminating the necessity for licenses in multiple states, allowing Marylanders who move to compact states to continue their behavioral health services, and lastly, Lastly, it would provide Maryland's authority to hold a licensed professional counselor accountable for meeting all the practice laws in the state of Maryland if their client is here, thereby protecting public health and safety. The National College Health Assessment and Healthy Mind Study between 2007 and 2018 found a worsening of depression, anxiety, low flourishing, and suicidal planning and attempts among college students, with suicidal thinking, severe depression, and self-injury rates doubling between 2007 and 2018. And in Maryland, anxiety among adults aged 18 and older increased from 27% in April 2020 to 34% in January of 2021, while depression amongst adults aged 18 and older also increased from 20% in April 2020 to 27% in January 2021. Maryland has more than 50 colleges and universities and over 130 private career schools and several military bases. These schools enrolled over 345,000 students for the fall of 2020 academic year. Maryland has very strong academic institutions which attract students from all over the country and the world. And of note, University of Maryland, as an example, has 1 in 3 to 1 in 4 undergraduate students that are coming from out of state. And military bases also bring large numbers of people to Maryland annually. The impact of COVID has shown that these populations are at risk for increased mental health support and behavioral health needs. The need to access services as they move in and out of the state for school or service obligations must be provided with open access and minimal interruptions while they are learning and working in the state of Maryland. The added stressor that relocation can cause,
Dr. Jones, if you could start to wrap up, that would be great.
Stressor for many, can make these individuals more vulnerable than at their baseline. The need for mental health support for college students who may live outside of the state but attend a Maryland university has caused strain on school counseling centers. Therefore, MDH respectfully requests a favorable report on SB 571 so that all Marylanders can access the care they need most conveniently and effectively to improve access to professional counseling services and continuity of care. Thank you.
Thank you, Dr. Jones. Jeffrey Galecki, Maryland Board of Professional Counselors and Therapists, followed by Rachel Faulkner and Christopher Arnold. Jeffrey Galecki, you may begin up to 2.5 minutes.
Thank you so much. So I'm the chair of the Board of Professional Counselors, and we overwhelmingly support the passage of this bill for a lot of the reasons some of the other compacts have been proposed or passed in the past. We feel that it's greater access to care for patients in Maryland, greater license portability for the licensees themselves. As has already been cited, and I won't really get into details on, we have a number of pandemics and a number of mental health crises going on. We feel that there are only benefits to this compact, and we've discussed it on our board. Not only would we like a favorable vote on it, but we are very interested in being actively involved in the commission that would be set up to run this compact and be involved in that if it were to pass in Maryland and become a part of our laws. Thank you so much, everybody.
Thank you for your succinct testimony, Mr. Galecki. Next, as I said, Rachel Faulkner for LCPCM. Ms. Faulkner, welcome.
Thank you. Thank you, Chair Pinsky and Vice Chair Kagan. Rachel Faulkner here with the Licensed Clinical Professional Counselor.
Ms. Faulkner, you're really quiet. If you can move forward, that would be helpful. Nope, now we don't have you at all.
Oh no.
Nope, I'm wrong. We have you. You're good. Okay, please go ahead.
Okay, thank you. So again, Rachel Faulkner here with the Licensed Clinical Professional Counselors of Maryland in support of Senate Bill 571. This compact was developed by a national task force, which included LCPCM's national affiliate, the American Mental Health Counselors Association. I just want to first thank the governor and lieutenant governor for recognizing the importance of licensed clinical professional counselors within Maryland's behavioral health workforce and introducing this legislation. There are over 4,000 licensed clinical professional counselors in the state right now, and within their scope of practice, they can diagnose and treat mental health conditions in various practice settings. I think that there's several benefits of the compact that I don't need to go into because I know that, I think Dr. Jones did a really wonderful job of laying those out. What I would say is a couple additional benefits. We know that even before our current healthcare pandemic, that there was a workforce issue with behavioral health services and behavioral health providers. And a compact also helps behavioral health programs and employers who may or want to recruit licensed clinical professional counselors from out of state. Currently, those practitioners need to get a single state license in Maryland, even if they have a license in Pennsylvania, the district, Virginia. And so this reduces that barrier, hopefully really helping hospitals and mental health programs and other, employers recruit those practitioners from out of state. And so, for these reasons, we are urging a favorable report. Thank you.
Thank you, Ms. Faulkner. And I should have said earlier that there is no, not only is there no opposition to this administration bill, but yeah. So Mr. Arnold, please wrap us up. Defense State Liaison.
Thank you, Madam Chair. As I stated earlier, I'm Christopher Arnold, the Northeast Region Liaison for DOD. And on behalf of DOD, we appreciate the opportunity to support Senate Bill 571. DOD encourages states to engage in immediate actions to fully implement military spouse licensure laws, near-term actions to at least attain a baseline of getting military spouses a license in 30 days based on minimal documentation, and long-term solutions for reciprocity through interstate licensing compacts. The secretaries of the military departments have made the importance of military spouse licensure explicitly clear as they consider the availability of military spouse licensure reciprocity when evaluating future basing decisions or mission alternatives. How fast these actions and solutions can be approved and implemented is up to the states. Occupational licensure compacts provide consistent rules for licensed members to work in other states. Common misinformation about compacts is that they either lower or raise the standards for the occupation, when in fact, compact states have the option to issue a compact license and also a state-only license to maintain their state standards. The military provisions added to these compacts assist service members and their spouses. The benefits to the military are clear. The Interstate Licensed Professional Counselors Compact, or LPCC, seeks to eliminate barriers to interstate professional counseling practice, improve patient access to professional counseling services, and enhance public protections through a shared interstate licensure data system. Of additional benefit is the compact's utilization of a mutual recognition model of interstate practice, which enhances opportunities of portable careers for military spouses by providing consistent rules which allow licensed members to work in other states through privilege to practice policies or more easily transfer their license to a new state. Military families move every 3 years on average. LPCC helps military spouses relocate and begin work without delay by reducing the amount of time and effort needed to gain authorization to practice in a new state, even as compared to expedited licensure laws for military spouses. Joining LPCC will improve access to counseling resources and allow military personnel and spouses to more easily maintain their certifications when relocating. The history of Maryland's support for our service members and their families these last 17 years is a rich and enduring tapestry. An enactment of Senate Bill 571, making Maryland the inaugural state in the Union to join the LPCC, will weave yet another thread into the fabric of that remarkable tapestry. As always, as Northeast Region Liaison, I stand ready to assist and answer any questions you may have with respect to the DoD position on this item and our support for other interstate compacts. Thank you.
Thank you, Mr. Arnold, and wishing you best of luck as you continue to inform us as to how our proposed state laws would affect the federal perspective. So thank you for joining us.
Thank you, ma'am.
No questions. So that completes the hearing on Senate Bill 571. Handing it back to the chairman. Thank you.
Thank you, Madam Vice Chair. Thank you very much to witnesses and sponsors. We're going to 597, Senator Washington State Board of Social Work Examiners Revisions. We'll start with the sponsor, Senator Washington, followed by Stanley Weinstein, followed by Gerard Farrell and Daphne McClellan. I do not see any opposition in the file, although there are some favorable with amendments. Senator Washington, you're in charge.
Oh, thank you. Thank you so much, Chairman. Thank you, committee. For the record, Senator Mary Washington, 43rd District. Honored to, let us just look at my panel and note that we have a rare kumbaya moment, I believe, here at where we have everyone together. They've all been working very hard on this, so I'll just be very straightforward that this is a cleanup bill, and it's to update the Maryland Board of Social Work Examiners statute. They completed a comprehensive review of their statutes and what was needed to be updated and what kind of necessary changes we needed and support with, again, all of these entities here. we have, I believe, come to a bill. Now it's not perfect, so I've uploaded one amendment to the bill with my original testimony. It was simply a mistake in the original bill draft, so there's an edit there. We're also willing to sort of concede and look at other supports, other amendments. So with that, I will leave the details to those who know them best and ask for your favorable report of Senate Bill 597. And again, the order is as you have, except I would like Dr. Weinstein first as the lead proponent, and then Daphne McClellan, who's representing NASW, and then Jerry Farrell. Thank you so much.
That's fine. Mr. Weinstein.
Chairman Pinsky, Senator Washington, and committee members. Thank you for the opportunity to talk about Senate Bill 597. It incorporates changes as a result of, as Senator Washington said, a complete review of our statute and regulations over a 2-year period. It removes dates that are no longer relevant, removes obsolete language and some language to enhance mobility and make our statutory language more consistent with neighboring states. And I'll try and just highlight some of the key things. We have a license category called licensed certified social worker. There's only 350 individuals licensed as such out of 16,000. So we are eliminating that in 2023. It is being covered by another category of licensure, the licensed master social worker independent. We have replaced the licensed graduate social worker license, so we've eliminated that. We had a federal government exemption that before didn't have any qualifiers. Now it does, because if that one state, the federal employee is licensed and is Maryland, then they have to comply with Maryland laws. They're not exempt. A significant change was a reduction in the hours of supervision required for our clinical license. And this was done because our focus is more on quality than the number of hours, and we wanted it to be consistent with our neighboring states, such as DC, Virginia, New York, and Delaware, all had 100 hours of supervision where we had 144. And another significant change is actually the amendment that Senator Washington was talking about. We had in our statute that in 2021, we would begin having criminal background checks for all licensed social workers who hadn't done so. We feel that during the pandemic is not the time to ask for that. And also the main driver of that is the FBI's RAP-Back system, which notifies states when someone's been criminally charged, is not fully effective yet. So we've asked that to be postponed to 2023. We are entering disciplinary history into our electronic record. So when people, employers want to see if someone has had a disciplinary history, they now on our verification page will find that. Another change, and again, it's catching up with other state laws. State laws were passed to increase maximum fines for health boards from $5,000 to $10,000, and that is changed in this. And the last thing is the name of it. It was the Social Work Act to now we wish it to be called the Social Work Practice Act, pardon me. One I overlooked, we had a committee, the Social Work Rehabilitation Committee, that actually never really worked as a full committee. We're now calling it a social work rehabilitation process where we assist people who have problems, physical problems, behavioral health problems, problems that warrant additional help. And that summarizes pretty much the changes. The board requests support for Senate Bill 597 as amended, and I'll be glad to answer any questions you have.
Thank you, Mr. Weinstein. We'll go to Ms. McClellan. Unmute, please, ma'am.
Good afternoon, Senator Pinsky, Senator Washington, and members of the committee. I'm Dr. Daphne McClellan. I'm the Executive Director of the Maryland chapter of the National Association of Social Workers. And I would like to urge support of Senate Bill 597. We think that these changes are all terrific and necessary for our Practice Act. There was an issue in the original draft, and the sponsors worked very hard to help us come to consensus about this. And there's no one I'd rather hold hands and sing Kumbaya with than Dr. Weinstein and Mr. Farrell. So we urge your support. Thank you.
Thank you, Ms. McClellan. Gerald Farrell, please.
Good afternoon, Mr. Chairman and members of the committee. Thanks for the opportunity to appear before you today on the matter of Senate Bill 597. I am Jerry Farrell, Chair of the Maryland Board of Social Work Examiners, and I speak today on behalf of the full board, and I'll also be brief. I should also note that I am not a social worker. Rather, I am one of 2 consumer members on the board. I'm a retired Navy captain and a retired nonprofit executive and a member of the Board of Social Work Examiners for more than 4 years now. Our board unanimously supports this bill, which is essentially designed, as Dr. Weinstein said, to clean up the Social Work Practice Act, make the language in the statute consistent, and excuse me, and update the board's procedures. These revisions come after a long and assiduous review of the statute by the board's Statute and Regulations Committee and ultimately the full board itself. As Dr. Weinstein outlined, the most significant changes proposed are to reduce the number of clinical supervision hours required to obtain a licensed certified social work clinical license from 144 to 100. This is a considered effort by the board to support the national movement to license mobility and aligns us more closely with licensing requirements of our neighbor states. Excuse me. The next is to replace the Social Work Rehabilitation Committee, a committee that was never operationalized by the board, with a social work rehabilitation process that more closely aligns with the actual practice of the board over the past several years. And finally, to delay the requirement for criminal background checks from 2021 to 2023, a necessary change given the delays in obtaining such checks caused by the ongoing pandemic. Our board has worked closely and collegially with other interested parties on these changes, and we believe we have a bill that is straightforward and uncontroversial. We urge a favorable report by the committee. Thank you for your time.
And thank you. Are there questions for any of the panelists? Questions for any of the panelists? Seeing none, that concludes the hearing on Senator Washington's bill. We go to the final bill of the day, Senate Bill 646, Senator Carrozza, alcohol and drug counseling. She will be followed by Patrick Maddox, Paris Brooks, Dwayne Gould, and then Howard Ashkin. There are no opponents signed up, so we should take that into consideration. Thank you.
Thank you, Mr. Chair. Thank you, Madam Vice Chair, members of the committee. I respectfully am asking for your enthusiastic support for Senate Bill 646, alcohol and drug counseling, alcohol and drug trainees practices through telehealth. This bill, which is co-sponsored by our Vice Chair Kagan, is intended to provide a permanent allowance for alcohol and drug trainees to provide services via telehealth after the current public health emergency declaration has been lifted. As way of background, last spring, the Board of Professional Counselors and Therapists recommended that alcohol and drug trainees, or ADTs, be allowed to provide services via telehealth. This was a life-saving measure as ADTs represent 40% of the overall workforce at the certified level. Mr. Chair, this committee understands that we still have an opioid crisis, and this bill makes a difference. Most of our districts are hard hit by the healthcare workforce shortages, especially in the rural parts of our state. Our providers need flexibility to provide both in-person and telehealth services. I want to point out to my colleagues that the experience in the field in the last 10 months with the use of telehealth among all providers has been overwhelmingly positive. Behavioral health programs have seen decreases in no-show rates. They have seen increases in retention rates. They have had flexibility in conducting appointments to better meet the needs of the clients who most need those services. There's been significant client satisfaction with these telehealth services. This bill simply removes a statutory barrier that would prevent ADTs who are currently providing services via telehealth to continue to do so. The bill does not change the scope of practice of ADTs nor the supervision requirements. I want to go right to the heart of this. Access to alcohol and drug counseling through telehealth is increasingly important, especially given the devastating data from the Maryland Health Department and the Opioid Operational Command Center. There were 2,025 overdose deaths in Maryland in the first 3 quarters of 2020. My colleagues, this is a 12% increase from the same period in 2019. There are also disturbing trends related to the impact of opioid overdose deaths among Black and Hispanic communities. These numbers make it clear that Maryland cannot let up in our efforts to provide the needed counseling services and treatment to those with alcohol and drug addictions. Senate Bill 646 would just ensure that alcohol and drug trainees can continue to provide telehealth services after the COVID-19 pandemic. I want to point out, Mr. Chairman, as you already did, not only is there no opposition, there's over 25 groups in support of this or more. And I want to just highlight 3 of my locals: Peninsula Mental Health and Addiction Services in Salisbury, the Eastern Shore Behavioral Health Coalition in Easton, the Midshore Behavioral Health also in Easton, and Huntston Behavioral Health in Salisbury. The bottom line is that we know that alcohol and drug counseling services are critical. With the expanded use of telehealth throughout our healthcare system, including the allowance of the ADTs to provide these services for the past 10 months, it only makes sense to allow the ADTs to continue to provide these telehealth services so more clients can benefit from these counseling services. With that, I conclude and welcome my witnesses to share the rest of the story. Thank you, Mr. Chair.
Thank you. Patrick Maddox, please.
Good morning, or afternoon, I'm sorry. My name is Patrick Maddox, and thank you, Senators, for the opportunity. I'm here on behalf of the Maryland Addictions Directors Council and the Maryland Association for Treatment of Opioid Dependence, and are seeking your support for the permanent allowance of alcohol drug trainees to provide services via telehealth after the public health emergency declarations are lifted. I work for a company called Project Chesapeake. I am the program development manager. I'm also an individual with lived experience. And I get the opportunity to work with all of our staff, including our substance abuse treatment staff. We provide services across the state of Maryland in 10 different counties, including the Lower Shore. We provide substance abuse treatment for inpatient and outpatient services. And I work directly with our staff, including ADTs and the clients we serve, to help improve our programming. We all agree that delivery of telehealth services during the pandemic has removed barriers and has provided tremendous opportunities for individuals to access and participate in treatment. In my day-to-day duties, we see more individuals connecting to substance use disorder treatment services than in the past, and many share their gratitude for this opportunity. We value our work with ADTs, and we support this bill. I had a few more remarks, but I'm going to keep it short so that others can share.
Thank you very much, Mr. Maddox. Can we have Paris Brooks, Dwayne Goulden, and Howard Ashkin?
Oh, good afternoon, everyone. My name is Paris Brooks, and I work at Institute for Behavior Resources located in North Baltimore. As a quick background, IBR provides comprehensive recovery services, including all medications used to treat opioid use disorders. IBR serves over 1,800 people per year and employs licensed counselors, therapists, and ADTs like me that help clients with their substance use issues. While I currently maintain a trainee status, my functions are very similar to that of a licensed counselor. Typically, I conduct 15 to 30-minute sessions with each client to better understand and assist them with their substance use. The caseload that I currently have and work with each day mirrors what a licensed counselor would do. When the pandemic began, IBR, like many clinics, attempted to find ways in which we could continue delivering services to clients while ensuring safety and privacy. Telehealth services are just as important to an ADT as any licensed counselor. Our clients who share personal information and have developed a bond with the counselor will suffer if we are unable to continue these services. The ability to see each client in person is just impossible given the size of my caseload and the rooms that we conduct our sessions in, possibly being occupied by another counselor. I am completely in favor of this bill, and my hope is that all trainees like myself are afforded the opportunity to continue making a positive impact in the lives of the clients that we serve. Thank you all.
Thank you, Mr. Brooks. Mr. Gould.
Thank you, Mr. Chairman. Hello to Madam Chairman and committee members. My name is Dwayne Gould. I'm currently a program director for ATS Starting Point, which is an opiate treatment program in the state of Maryland. And we are in favor of Senate Bill 646, allowing alcohol and drug trainees to continue to provide telehealth services after the public health emergency would be something that would favor the participants that we service. ADTs make up a large percentage of the workforce in the substance use disorder field in the state of Maryland. With that being said, it is important to programs across the state that this bill will pass. Gone are the days of providing traditional group and individual therapy due to the pandemic. Telehealth services has allowed substance use disorder programs to continue to provide services to vulnerable populations in a safe manner. Not allowing ADTs to continue to provide services via telehealth would severely restrict some programs from providing services to individuals who might not want to come into a traditional setting due to continuing fears of the pandemic. It is my position as an individual who has provided supervision for ADTs over the last 10 years that with proper supervision, ADTs will be able to provide ethical and professional service via telehealth. In my opinion, nothing would change in regards to their scope of practice. ADTs would be providing the same services via telehealth as they would in a traditional setting, along with receiving the same amount of hours and supervision as they already would be in a traditional setting. In conclusion, I would like to restate my position of being in favor of Senate Bill 646. Allowing ADTs to continue to provide services via telehealth will be on par with the continuing changing of the landscape of service delivery within the public health system and the behavioral health system. Thank you. I yield my time back. Thank you.
Mr. Ashkin.
Thank you. Can you hear me?
Yep, perfectly.
Okay, great. Thanks, Chair Pinsky, Vice Chair Kagan, members of the committee. My name is Howard Ashkin, and I'm the immediate past president of the Maryland Association for the Treatment of Opioid Dependence, also known as MATOD. MATOD is a provider and advocacy association comprised of the majority of the state's 95 opioid treatment programs, or OTPs. Maryland OTPs currently provide comprehensive medication-assisted treatment for over 40,000 Marylanders with opioid use disorder. We urge a favorable opinion on Senate Bill 646, as was stated before, simply to continue the provision and allowance of alcohol and drug trainee counselors to provide telehealth services. I just want to highlight a couple of things that were said earlier, and that is that while this bill will permit the same telehealth services that the Maryland Secretary of Health and the Maryland Board of Professional Counselors approved in April of 2020, it does not change the existing COMAR regulations that define the ADT scope of practice, required supervision, and also important, the place of employment. ADTs are not hanging up their own shingles. They must work for a licensed, certified, accredited substance use disorder provider. MATOD members reported approximately 60% of their counselor workforce includes ADTs. And the Board of Professional Counselors in their most recent annual report stated that more than half of all alcohol and drug counselor applications were for ADT status, and more than 62% of certificates and licenses issued were for the ADT level of certification. The provision of telehealth counseling during the last 11 months has demonstrated its necessity and appropriateness and effectiveness. It's expanded access and availability to counseling, it's improved retention, and it's reduced systemic barriers and stigma. ADT counselors are an essential part of our substance use disorder workforce, and they support thousands of patients who might otherwise be without care. So we are grateful to Senator Carrozza and Vice Chair Kagan for introducing this bill, and we urge a favorable report.
Thank you. Question for the panel. Seeing none, that concludes our hearings for the day. Thank you for your patience and witnesses. Those working with Senator Hester will be texted or emailed a starting time. Okay, thank you all, and we'll meet back tomorrow. Thank you.
Mr. Chairman,
Yeah.
since it's supposed to be live streamed and announced, I think, shouldn't Senator Hester just announce? No, we're good? Sorry.
No, we're good.
Okay, all right, thank you. Bye.